Okay, we will go ahead and get started this afternoon. Welcome to the Atopic Dermatitis Regional Training presented by the Ohio Chapter American Academy of Pediatrics. This training is supported by a nationally funded quality improvement grant, and it will be a 3-part training. Part 1 will focus on mastering the basics of atopic dermatitis. Part 2, itchy skin is driving me crazy. Part 3, managing atopic dermatitis in the primary care setting. Just a few Zoom tips throughout this training. Please keep your lines muted and your cameras off. Our presenters will have their cameras on while they're talking. And you can use the chat box to ask any questions that you may have throughout the training. We have 2 scheduled breaks, and we will take the time to answer questions when those during that time. The objectives for today's training is to discuss implementation of dermatology-focused best practice in AD management and patient adherence to treatment, and then to develop skills in the mental health and primary care implementation of AD in pediatric patients. At the end of the training, I will send out a survey for you to complete, and that is how you will receive your training credit. Today, our speakers are Dr. Kara Shaw, Dr. Emily Harris, and Dr. Chris Peltier. At this time, they will take time to introduce themselves, and then we will get started.
Hi, everyone. I'm Dr. Kara Shaw. I'm a pediatric dermatologist, currently in private practice in Cincinnati. Previously, I was on faculty at Cincinnati Children's Hospital and the Children's Hospital of Philadelphia.
Hi, I'm Dr. Emily Harris, and I'm a triple board graduate from Pittsburgh. I'm here as a primary care pediatrician at Cincinnati Children's, as well as a general outpatient psychiatrist. I'm very interested in integrating mental health into primary care, so I'll be working on the itching drives me crazy section.
Hi, everybody. My name's Chris Peltier, and I'm a general pediatrician in private practice in Cincinnati, and I'm glad you all could join us. And I'm also the president-elect of the Ohio chapter.
Great, and then our presenters have no financial relationships to disclose, and no off-label products will be discussed. And then Dr. Shaw will get started with her presentation.
Okay, I hope everyone can see my screen. Welcome. I really want to thank the American Academy of Pediatrics for the invitation to speak today on a topic near and dear to my heart, atopic dermatitis, probably one of the more common diagnoses that I see in my practice. So hopefully I can share some information and tips with you on how to approach management of this common condition. Looks like it's not letting me advance my slides, Alex.
Let's see. Can you maybe stop sharing and then reshare again? See if that works.
Nope.
No. I'm not sure. I can.
I'll stop. If you want to drive, we can do it. That would be fine.
Do that. There we go.
Perfect. So just a quick overview of what I'd like to cover today, a brief introduction. I do want to spend some time talking about the diagnosis of atopic dermatitis and the differential diagnosis. We'll review the clinical features and talk a little bit about how to measure disease severity, which I think is important. I will then move into a few common complications and comorbidities, including assessment of food allergy, infection, very lightly touch on psychosocial complications, although you'll hear more about that from Dr. Harris, and then move into treatment and end with a few clinical pearls. Next slide. Next slide. So introduction. So I think you all recognize atopic dermatitis is very common. It's estimated to affect about 12.5% of children in the United States. And luckily, most children have pretty mild disease, and that's perfect for management by the primary care provider. Next slide. So how do we effectively manage our patients with atopic dermatitis? Well, I think it's important to remember a few things. Firstly, there is actually a pretty significant financial and psychosocial burden associated with this condition. And I think it's really important to recognize that and make assessments at each visit, and in particular, if you're struggling to manage a child, just to make sure that we're addressing all of those possible complications. So a successful management strategy for children with atopic dermatitis definitely includes the following. First, you want to make sure you have the right diagnosis. There are several other skin conditions that can mimic atopic dermatitis, and it's important to make sure that your diagnosis is correct. Second, I think it's important to set appropriate expectations with the patient and their caregivers. Otherwise, we're setting ourselves up for failure. Third, we want to make sure that we have appropriate treatment recommendations. Treatment recommendation paradigms can change fairly frequently, so we definitely want to stay up to date with what's available. And then fourth, we want to make sure that our patients are adhering to whatever we've recommended in terms of their management strategy. Adherence or lack of adherence is probably the most common reason why management fails. And it's really important that we address that at every visit, in particular if someone's not doing well. Next slide, please. Okay, so diagnostic criteria. Next slide. So the American Academy of Dermatology has established some essential diagnostic criteria for this condition. I think it's important to make sure that we're always reviewing whether these are present in our patient. So the 4 key criteria are pruritus, so itching is probably the most common complaint when people have atopic dermatitis. So that's a very key core criteria. Number 2, the dermatitis is eczematous in nature, and that typically includes some combination of erythema, exudate, scaling, crusting, and lichenification. This is a condition that tends to be chronic for at least some period of time, and relapses are pretty common. It's not a one and done condition. And then there are typical patterns with regards to morphology and distribution, and those tend to be fairly age specific. In infants and children, there's often involvement predominantly of the face and the neck and the extensor surfaces of the extremities. In older children and adults, more commonly there's involvement of the flexural areas of the extremities. There certainly may be involvement of other areas. And classically, atopic dermatitis spares the groin and the axilla. Next slide, please. So there are several other important criteria that are not mandatory, but I think can be helpful in assessing if you're trying to make a diagnosis. And that includes early age of onset, usually before age 2 years. There certainly are children and even adults who present at an older age, but again, classically, this tends to show up very early in life. There's often a personal and or a family history of other atopic conditions. So others in the family with atopic dermatitis, asthma, food allergy, environmental allergies. Serum IgE levels are often elevated. And usually there is some degree of underlying xerosis and occasionally Ichthyosis vulgaris. Next slide. So historically, you may have heard of reference to the Hanifin and Rajka criteria, and these were set forth in 1980. They're fairly extensive. I do think it's helpful to review them because although we don't tend to use this in clinical practice, it's really more of something that's used in research, clinical research these days. I think it's a very nice summary of some of the other key features in terms of clinical exam or history that you can see in patients with atopic dermatitis. So the key criteria, or the major criteria, which certainly overlap with the criteria set forth by the American Academy of Dermatology, include the following 4 criteria. You really should meet at least 3 of them in order to qualify for a diagnosis of atopic dermatitis. And that includes that personal or family history of skin or respiratory allergy, pruritus, a chronic and relapsing clinical course, and then that characteristic morphology and location that's often age dependent. Again, infants often have a lot of atopic dermatitis involvement of the face and the extensor surface of the extremities, while the adults usually will have some history, at least, of flexural involvement. Next slide. So there are multiple other minor criteria, and in general, if you're trying to meet the diagnostic criteria according to Hanifin and Rajka, you should meet at least 3 of these. And they include the following. It's a fairly extensive list. Number one, susceptibility to skin infections in general with Staphylococcus aureus or herpes simplex virus. This implies some degree of impaired cell-mediated immunity at the level of the skin and the skin immune system, immediate or type 1 type hypersensitivity, skin test reactivity, and that goes along with elevated serum IgE, that early age of onset, a tendency towards cirrhosis, Ichthyosis Vulgaris. You'll often see hyperlinear palms, increased frequency of keratosis pilaris. Many children and adults with atopic dermatitis will also have this tendency towards this somewhat nonspecific hand and foot dermatitis, and sometimes that's the only manifestation as they get older. Nipple eczema is also fairly common, and that can occur across all ages. Next slide, please. Perifollicular accentuation, or what we often call follicular eczema. This is characteristically more common in darker skin types, but can be seen in anyone. In general, it's not uncommon to have a course that's influenced by stress, emotional stress, environmental factors. Facial pallor or erythema, sort of at baseline, is often common. Pityriasis alba, infraorbital hyperpigmentation, Denny Morgan lines, we often think of those as going along with the allergic component, recurrent conjunctivitis and keratoconus. Next slide. Anterior subcapsular cataracts are fairly specific for atopic dermatitis, although in my experience fairly uncommon, especially in light of the fact that I think we don't tend to use a lot of systemic steroids these days for atopic dermatitis. Involvement of the anterior neck folds is fairly common. Cheilitis, often in association with facial involvement. An intolerance to things that are irritating, wool fabrics, lipid solvents, so things with alcohols or acetone in them. A phenomenon called white dermatographism, which in contradistinction to classic dermatographism, doesn't involve a classic wheel and flare, but in contradistinction, when the skin is stroked, there may be a little bit of erythema, but the predominant reaction is one of pallor. And that's proposed to relate to some degree of sort of vascular reactivity. Itching with sweating is very common, and then food intolerance or allergy. Next slide, please. So let's run through a couple of pictures. I think it's always easiest to explain things when you can visualize them. So here's a child with some foot dermatitis as part of her atopic dermatitis. And then she also has pretty extensive Ichthyosis vulgaris, so that dirty, dry, fish-like scaling that's pretty common on the extremities. Next slide. Hyperlinear palms, maybe a little bit hard to appreciate in this picture, but you can certainly see some accentuation of the skin line markings on the palms, even in the absence of active dermatitis there. And then you can see she has fairly extensive involvement on the arms. Next slide, please. Here's that follicular prominence or follicular eczema. I see this fairly commonly in younger children. Next slide. Pityriasis alba, so that classic hypopigmentation, often on the face, although you can see it in other locations. It's usually fairly ill-defined. There may be some very mild scaling associated with it, and it can be fairly noticeable in darker skin types and easy to miss in lighter skin types, but very common in children with atopic dermatitis. Next slide, please. And here's a child with perioral atopic dermatitis and then cheilitis, so those poor lips are cracked and edematous. Next slide. Foot dermatitis, again, I see this a lot across all age groups, so acute and subacute erythema and scaling and crusting can be very difficult to manage. Next slide, please. Hand dermatitis, similarly, often seen in association with foot dermatitis, and also can be fairly recalcitrant to therapy. Next slide. So clinically, we talk about acute and subacute dermatitis and chronic dermatitis, and your acute and subacute presentations are where you see that erythema and scaling and crusting. There's usually pretty significant itching. There's a lot of scratching. There's often exudate and erosions. Next slide. And then the chronic features skew more towards lichenification and hyperpigmentation of the skin. These result from chronic rubbing and scratching of the affected areas. There's always this itching or pruritus associated, and sometimes there may be erosions and crusting too. Next slide, please. So pigmentary changes are also very common in atopic dermatitis, and they may include both hypopigmentation and hyperpigmentation. And these are post-inflammatory phenomena. And I think it's important to recognize that this does not occur from the use of topical corticosteroids, but it results from the prior inflammation that is usually better by the time you see the hypopigmentation. And unfortunately, what that does is it temporarily decreases the ability of the melanocytes to make pigment. They kind of drop out of the skin, and so you lose your normal skin color in those areas. But once the atopic dermatitis, the dermatitis is well controlled, the skin color should return to normal again. And then similarly, hyperpigmentation, we do see this fairly commonly in darker skin types. Next slide, please. So let's move on to disease severity. There are many atopic dermatitis severity indices that are available. They are used predominantly in clinical trials. I mentioned them just for the sake of completeness, but the one that I think can be helpful in terms of clinical practice is the investigator global assessment. And being comfortable with it, I think just helps to give you a sense of how to stratify disease severity in your patients so you can make appropriate choices about treatment and referrals. Next slide. So the investigator global assessment is really just a 5-point scale, although you can use half points more again in research settings, but it ranges from a score of 0, which is clear, up through almost clear, mild, moderate, and then severe. Next slide. So this is a quick summary in one single table. I'll review each score in a little bit more detail in the next few slides. Next slide, please. So an IGA score of 0 is essentially clear. You know, they've had atopic dermatitis, but really all of the redness, all of the induration, all of the crusting and lichenification, it's all gone. You may see some post-inflammatory pigment changes, but those acute or chronic clinical signs have resolved. Next slide. So an IGA score of 1 means almost clear. This is really just barely there disease. And so the erythema is barely perceptible. There may be the slightest degree of induration that you can feel in the affected areas. There's little to no lichenification, and there really shouldn't be much oozing or crusting. Next slide. So then an IGA of 2, mild disease. So this is a little bit more prominent erythema, albeit it's usually fairly light in color, but you can definitely see it. You can usually feel a little bit of induration or see some areas of skin that are more raised or papular. And you might see some areas where there's a little bit of lichenification, but there usually isn't any significant oozing or crusting. Next slide. And here's an example of mild disease in a darker skin type. So there may be a little bit of erythema. Sometimes that's hard to appreciate. I think you can see the lichenification, so accentuation of those skin markings. There is a little bit of hyperpigmentation associated with that. But again, no oozing and no crusting. Next slide. So moderate disease. Here we can see more notable erythema or redness. You can really appreciate, especially if you're feeling the skin, that there's induration there. The skin may be raised. If there's lichenification, it's pretty obvious. And now you may start to see a little bit of oozing or crusting or really prominent scaling and desquamation. Next slide. And then severe disease, so in this child, pretty marked lichenification and scaling. There may be some areas there where there's some oozing or crusting that you can't appreciate. Next slide. And then in this child, you can really appreciate the erythema. It can be quite deep or bright red. There are often areas that are quite indurated, and there's usually some significant degree of oozing or crusting. Next slide. So I think becoming comfortable with being able to stratify your patients into sort of minimal, mild, moderate, and severe disease is helpful. So again, here's a child with an acute dermatitis as part of their atopic dermatitis. And I think you can see there's, redness. It's not dramatic. There may be a little bit of scaling, a little bit of some induration there. Looks like there's a little bit of crusting that's starting to form. So, depending upon how you view this, you may view this as sort of mild disease. But once you've fixed that in your mind and you've documented that in your chart, I think it's a lot easier to then go back once you've made some management recommendations and assess how that child is doing. Are they the same? Are they better? Are they worse? Next slide, please. So another child, a little bit maybe more marked erythema, obviously some areas where there's some crusting. They've probably been scratching. Next slide. And then again, that child with sort of mild chronic dermatitis. Next slide. And then pretty severe chronic dermatitis again. Next slide. Here's another child, pretty extensive lichenification. There's been some crusting. This child has excoriated themselves. There's actually some ulceration there. So more severe disease. Next slide. So let's move on to differential diagnosis. So again, there are several common skin conditions that can mimic atopic dermatitis, and I think it's important to become familiar with them and how we differentiate them from atopic dermatitis. So some of them are common things that we see. Seborrheic dermatitis, especially in infants, this can be fairly widespread. Scabies can often be the great mimicker of many things, including atopic dermatitis, but your history should hopefully help you sort that out. Nummular eczema, contact dermatitis, whether it's allergic or irritant, and it's important to recognize that these may actually coexist with atopic dermatitis. And then psoriasis, which also may coexist with atopic dermatitis, but usually once you're familiar with the conditions, you can differentiate them pretty reliably. And then rarely, which I'm not going to belabor, but there are several congenital conditions in particular that can present with eczema-like skin eruptions, and that may include various forms of congenital ichthyosis, as well as some immunodeficiency disorders. Usually in these instances, there's something else going on with the child, and it's obvious there are some red flags that indicate that this is not just garden variety atopic dermatitis. Next slide, please. So seborrheic dermatitis. So here's an infant with pretty typical seborrheic dermatitis. Although you can't see the scalp in the picture, usually they have some cradle cap-like manifestations, greasy crusting, some erythema. This often extends down onto the face. And then there's accentuation in the skin folds and the diaper area of these sort of ill-defined erythematous patches. There's this very greasy sort of scaling. Really, the morphology is distinct from atopic dermatitis. This can be fairly generalized. So you can see it on the trunk and other areas on the extremities too. And then this typically self-remits and is not generally a concern once the child is older, but seen fairly commonly in infants. And again, there may be some overlap with atopic dermatitis, but this is a distinct clinical presentation. Next slide, please. Psoriasis usually shows up as pretty well demarcated, usually brightly erythematous plaques and patches. The scale is usually very coarse. There's often fairly significant scalp involvement and or a family history of psoriasis as well. And again, there may be some overlap between this and atopic dermatitis, but otherwise fairly distinct. Next slide, please. Scabies, so I think in classic presentation, fairly obvious. So on this child, multiple scattered erythematous papules, there may be some vesicles, the child is extremely itchy, they may be irritable. In younger infants, there may be some nodular component, and there may be a little bit of eczematization in some places, but the primary morphology is one of a papular eruption that is, again, just distinct from atopic dermatitis. Next slide, please. Nummular eczema, so this tends to present on the extremities usually, and spares areas like the face. You can see it on the trunk, but it's much less common. And this is often mistaken more for psoriasis, but sometimes for atopic dermatitis. In nummular eczema, there are usually one or more very sort of well-defined patches and plaques. They're oozy, they're crusty, there may be some itching, but they don't involve the typical locations that you would see in patients with atopic dermatitis, and they look quite different up close from psoriasis. Next slide, please. And then contact dermatitis, allergic contact dermatitis, so often very bizarre, geometric distributions of these acute dermatitis presentations, so ill-defined erythema. There's usually vesicles and crusting, but you shouldn't see lichenification, and you don't really see a lot of scaling with allergic contact dermatitis. Again, there may be some overlap with atopic dermatitis, and certainly when you have atopic dermatitis, you can develop contact dermatitis to some of the things that are used to treat you. And it's important to always consider that in a patient who's not doing well with the treatment plan, as you would expect. But isolated, odd, acutely eczematous patches and plaques would be atypical for atopic dermatitis. Next slide, please. Irritant contact dermatitis. So this is fairly common. This is a child who had some issues with nighttime uresis. They were in a pull-up. They would get very irritated from urine overnight. So again, these sort of odd, geometric, relatively well demarcated patches. There's a little bit of scaling. There's a little bit of some erosions and maybe crusting there. But the distribution is odd for atopic dermatitis. And with a little bit of history, you can usually tease out what's going on there. Next slide, please. Okay, so let's move on to treatment. Next slide. So some general suggestions for treatment guidelines. I think the basics with regards to skincare are really important. We want to make sure that all of our patients with atopic dermatitis are doing the basics right, and that includes using gentle, hypoallergenic, non-soap cleansers. We really try to stay away from the dial soaps and the Axe body wash. We want to make sure that patients are using moisturizer after bathing and as needed. My preference, again, tends to be for hypoallergenic products, usually creams as opposed to ointments or lotions. We want to make sure that bath time is fairly quick, and they're using warm water, not hot water. They're not rubbing and scrubbing with washcloths and loofahs and things that might be irritating, and they're keeping their fingernails short. We want to make sure if there are triggers such as irritants in the environment, and that may include things like heat and sweating or certain fabrics, that we're trying to minimize exposure to those. If the child does have a known history of allergy to things like foods or animals or environmental allergens, we want to make sure that we're avoiding those. Next slide, please. Quick talk about skin cleansers. So we do generally recommend that children with atopic dermatitis are using a sort of surfactant-based detergent, a Syndet, as opposed to old school traditional soap. These are generally alkalinized oil-based products. Some of the things that I like and recommend would include products made by Dove and Cetaphil, CeraVe, Vanicream, which is my personal favorite. They all make bar as well as liquid cleansing products, and I think most children tend to tolerate them reasonably well. Next slide, please. Moisturizers. So there's lots of them out there. It's important to understand the difference between different types of products. And the three main vehicles that we tend to see would be creams, my favorite. These are considered oil and water emulsions. They are the most hydrating of your moisturizing products. I think they're the most acceptable in terms of how they feel. And we'll go over some suggestions for products that I like in an additional slide. Ointments, which are things like Vaseline and Aquaphor and Dermaphor. These are water and oil emulsions. So they're very greasy, they're very occlusive. Although they do create a good barrier seal on the surface of the skin, I think sometimes they're just too uncomfortable for people to use in large areas. They can contribute to acne. Sometimes in warmer months, they're just too hot and occlusive to use. And they don't really hydrate the skin as well as a moisturizing cream will. And then finally, lotions. These are also oil and water emulsions, sort of water-based products. They may often contain various alcohols to help to thin them and help them to evaporate a little bit faster. So they are less hydrating. And in my experience, they can be irritating for people who have atopic dermatitis or sensitive skin. Next slide, please. So some of the other important things to consider in terms of how we approach treatment. Number one, we want to make sure that when we are recommending medications, and for more mild disease, again, we're generally gearing towards topical medications, so corticosteroids, corticosteroid-sparing agents, that we're using them appropriately for the age of the child, the location of the atopic dermatitis, etc. We always want to make sure that we're addressing any component of stress or anxiety, and this includes not only the child, but their caregivers too. I also think it's important to understand who the caregivers are. Sometimes it's not always the parents. There may be other family members involved or other people involved in the care regimen, and we need to make sure we know who they are and that they understand their role in helping to manage this child's atopic dermatitis. And then infection can be a problem as well for these patients. And there are some strategies to help to minimize the chance of recurrent skin infections, albeit this is usually a problem of more severe disease. But some of the things that can be helpful that you're probably aware of include using bleach baths or swimming in chlorinated pools or using antibacterial cleansers. These are not products, or these are not recommendations that are geared towards everybody with atopic dermatitis. They're really fairly specific for issues of infection, as are use of topical antibiotics. Next slide, please. So what about bathing? We get a lot of questions about bathing. What's the right way to make recommendations around bathing? And it's confusing. And I think that partly this is because there's no one answer for everybody. We have to understand some of the restrictions that may be relevant with that particular child. We may have to consider concerns about the family and what they have available in terms of bathing routine. We really want to gear our each patient and each family individually. Sometimes bathing is uncomfortable. Sometimes we're worried about infection. We're trying to help reduce the chance of infection. And sometimes there are concerns about how to use topical products after bathing. So I think it's really important to always ask at every visit, what is the bathing routine, and see if we can make some suggestions for improving it. But whatever we decide in terms of frequency, I think bathing time should always be pretty short, 10 to 15 minutes or less. Because the longer that you're in the water, actually the drier your skin gets, you're going to start to disrupt that epidermal barrier. And then that can lead to more itching and sensitization to things like fabrics and external irritants. Next slide, please. So topical corticosteroids. So the mainstay of treatment for atopic dermatitis is topical steroids. And we'll talk about this in a little bit more detail, but a couple things to remember. The potency of a topical corticosteroid is increased if the area that's being treated is occluded, or if you're treating an intertriginous area. And so these are areas that are at risk for skin atrophy. So you always want to bear that in mind. I tend to recommend ointments over creams or lotions. Your ointments tend to be a little bit more potent as opposed to the cream or lotion of a similar steroid and strength. And I do think that you get a little bit of benefit from that barrier repair effect of the ointment vehicle. And so they tend to be my preference with some caveats. Of note, there are topical corticosteroids that come in a variety of other vehicles, gels, solutions, oils, foams. These may have use in certain locations like the scalp, for example, but for general body use, I tend to stay away from them. And I think it's important to know which corticosteroids are on each patient's formulary. We want to make sure we're prescribing things that they can get at a reasonable price, and that we're choosing appropriately based upon the age of the child, the sites that we're treating, and the severity of their disease. So I did put one little reference on there that I have found helpful previously, just to provide a little bit more information about choosing topical corticosteroids. Next slide, please. So potency. So it's important to understand how steroids rank on a potency scale. So topical corticosteroids are graded from low potency or class 7 to ultra potent class 1. And the grading strategy actually uses a vasoconstrictor assay. So it doesn't correlate necessarily completely with anti-inflammatory effects, but it certainly is a helpful frame of reference for deciding what to use. So your class 7 low potency topical steroids are your hydrocortisone products. Your class 6 products generally are things like Desinide and low strength triamcinolone in cream forms. And then we go up through all the way up to class 1, which would be products like clobetasol or halobetasol. You really would rarely use these in children with atopic dermatitis. But this list really kind of covers, I think, the generic topical corticosteroids that are pretty affordable and pretty easily accessible on most insurance and Medicaid formularies. Next slide, please. So I know there's always a lot of concern around overuse of topical steroids and side effects such as atrophy. And it's actually pretty hard to hurt yourself with topical corticosteroids when they're used appropriately, but it certainly is concern. And I think it's important that you're always monitoring for atrophy as a side effect, and that you're always reviewing how your patients are using their medications, how much, how often, where, for how long. I don't typically set hard and fast restrictions on how long someone can use topical corticosteroids. I tend to recommend that they start off twice a day and stress that twice a day is enough, not 4, 5, 6 times a day. And that gradually over the next week or 2 or so, as things improve, they should start to use that topical corticosteroid less often. So they may go to once a day for a few days, then every other day. They don't necessarily need to just stop abruptly. If you stop too soon, then either you haven't gotten to the point where things are better yet, or they're going to flare fairly quickly. And so this sort of strategy of sort of, gradually decreasing actually seems to provide better control, and in the long run seems to help to minimize the flares and then minimize the overall use of the topical corticosteroids. But for sure, if there's been no improvement after using a topical corticosteroid twice a day for 2 weeks, it's probably worth reassessing and trying to ascertain whether something else is going on. Why isn't this child getting better? Is there an infection? Do we need to adjust the therapy? But I don't usually recommend hard stops after a certain length of time. Next slide, please. So here's an example of some striae. So you can see the obvious areas of linear erythema and some atrophy there. Classic location on the skin fold areas of the inner arms. So those are high risk, as are places like the face and the popliteal fossa. Next slide, please. So some other key recommendations for prescribing topical corticosteroids: make sure you prescribe enough, albeit not too much. So one of the common issues that I see is someone's been prescribed a topical corticosteroid and they don't seem to be getting better, but the actual history when you drill down is that they're only being dispensed a 15-gram tube of medication and they need much more. And it works, after a week things are better, but then they run out. Then they can't fill their prescription again for another couple of weeks. So it's always important to make sure that you're prescribing enough medication, and that may require the use of certain terminology on your prescriptions, but that you're getting them through that 1 month period so that they don't run out too soon before they're able to fill again. Conversely, you don't want to be over-prescribing medication. If someone just has small areas of atopic dermatitis on the intercubital fossa, they probably don't need, a 1-pound jar of a topical steroid. the more they have of something, the more they will probably use it. And then to some degree, we can run into some problems there. But you can get some topical corticosteroids in 1 pound jars. And so if that's appropriate, that does make things easier for families if they do need to cover a large body surface area, so they're not trying to deal with lots and lots of tiny tubes of medication. I do find that many pharmacies will dispense the smallest tube available in multiple quantities if you're writing for a larger amount. And unless the family specifically wants that, sometimes that's just frustrating for them. So I also recommend that they discuss with the pharmacist whether they can actually order larger size tubes of things just to make it easier on them. And then also we want to make sure that patients and caregivers are not using the corticosteroids as moisturizers. I do hear that sometimes. They're just kind of putting it everywhere, which is obviously not appropriate. So the way that I like to instruct them to apply the topical steroids is to place a small amount on a fingertip and then basically dab a little bit, across the areas where it needs to be applied. And then they rub it in until it's really pretty absorbed. It doesn't need to go in thick like a moisturizer. I think if they take a big glob of it and put it all in one place and then try to spread it out, they wind up overusing the medication. And then that can increase the risk of side effects. And certainly you'll run out of medication sooner when used that way. Next slide, please. Generic medications, which I mentioned, I really rarely, if ever, prescribe branded medications. There's lots of good options for generics. And then understanding that sometimes people are afraid to use corticosteroids, and that can certainly lead to poor outcomes and to other concerns around non-adherence. So important to recognize that, address that, reassure your patients, review how they're using things, and make sure that they're not too afraid to use their medications appropriately. Next slide, please. So what about non-steroid medications for atopic dermatitis? Well, there are a few. I will say that using a topical corticosteroid in general will always work better for a flare than using something that's not a steroid, but they certainly have their role. And I think that in particular for patients who flare frequently and need to use something with some consistency, or for patients who are concerned about overusing topical steroids, there's certainly a nice adjunct to use in rotation with your topical steroids as the eczema or the atopic dermatitis does get better. And the options that we have today include 2 topical calcineurin inhibitors, so tacrolimus and pimecrolimus, and then a topical phosphodiesterase 4 inhibitor, which is currently only available as Eucrisa branded. So the 0.03% tacrolimus and pimecrolimus or Elidel cream are approved for ages 2 and up. Eucrisa is now approved for ages 3 months and up, and then the 0.1% of the tacrolimus is approved for ages 16 years and up. These are often considered step therapy, so you do often have to try and fail at least 1 topical corticosteroid before insurance will cover some of these other agents, albeit there are sometimes ways that we can work through that if we need to, because they can be expensive. Next slide, please. So in addition to cost, many of these products can sting and burn when they're first applied, so sometimes that's a deal breaker. Usually that application site stinging does get better after several applications, but it can be challenging to have a child who's already uncomfortable and then they're more uncomfortable when the medications are applied. So I typically recommend with the first few applications that the medication is used in 1 small area just to make sure that it's tolerated before it's used over a larger area. And these agents, in my opinion, are most appropriate for use in milder disease. They're really not terribly helpful for flares, again, for which we would prefer topical corticosteroids, but they are sometimes preferred for certain areas such as the face, where you might be a little bit more worried about using topical corticosteroids, in particular because of the risks of atrophy. Next slide, please. So I want to briefly talk about wet wraps. I think this is a helpful strategy to be able to recommend to your patients and their families. Wet wrap is a technique that helps to enhance the barrier repair function of moisturizers and topical steroids. It helps the topical steroids to penetrate the skin more and to work better. And they can usually be pretty easily performed by using something simple, like even just long john style pajamas. We often recommend using a type of tubular cotton gauze called Tubifast if we're treating certain areas. and if the family prefers that. But the basic technique is fairly simple. After a brief bath or shower, once the skin is hydrated, you're applying your topical medications where you need to, and then you're putting a moisturizer on. You're taking some of those tubular gauze or your pajamas, you're making them damp, so not sopping wet, but damp in some warm water and wringing them out. You're putting them on the child. They're staying in place for about an hour or two, or as long as that child will tolerate. They're putting some dry clothes on over top so they're not uncomfortable. And then after your time period is up, you're taking them off and you're moisturizing. And these can be very helpful for flares, and you can do them as often as 1 or 2 times a day. But in general, as things are getting better, you do want to start to back off because you are, again, increasing the penetration of those topical corticosteroids. So you don't want to put that child at risk for atrophy. And the occlusion sometimes can also increase risk for infection too. So just some caveats with how they're used. Next slide, please. So eczema action plans, I think it's important that families really understand what they need to do every day and what they need to do when things are bad, and then how they can transition back to things are better. And so there are a variety of ways to do this, and depending upon your office and your EHR and other considerations, I think there are different strategies in different circumstances, but I think it's important for families to have some written documentation of what they should be doing, and that documentation needs to stress how they're using their medications, as well as how they're doing their basic skincare every day, and they're not forgetting to do those things. Pointers on how to recognize a flare is helpful. Pointers on how to transition from using medications is helpful. And inclusion of use of certain adjunct therapies like wet wraps can also be helpful. So just kind of one reference that they can use to help decide what to do. And in particular, if there are multiple caregivers involved, it's really nice to have something in written form that they can refer to. Next slide, please. Okay, so let's segue into a couple complications and comorbidities. Next slide. So infection is one that we do worry about quite a bit, albeit fairly uncommon and pretty mild disease, but bacterial infection is not uncommon. And usually that is due to Staphylococcus aureus and less commonly Streptococcus pyogenes, so your group A strep. Colonization with Staph aureus, however, is fairly common. And so it's important to differentiate between those two, because not every child needs oral antibiotics because they have some bacteria on their skin. So trying to differentiate between colonization and infection is important. And then viral infections, Eczema Herpeticum, obviously, so herpes simplex virus infection. Children with atopic dermatitis are more common to more severe and widespread Molluscum Contagiosum infections. And then from a fungal perspective, uncommon, but there is some evidence that in some children, at least, Malassezia species can contribute to more recalcitrant atopic dermatitis flares of the head and neck area. So we'll go over all of these in a little bit more detail. Next slide, please. Okay, so bacterial infections, again, Staphylococcus aureus, very common, often just colonization. And it has been demonstrated that Staph aureus tends to overgrow on the skin in affected areas of those with atopic dermatitis, as opposed to unaffected areas of skin in which other Staphylococcus species tend to predominate. And this is thought to result from some disorganization of the local skin immune system response in combination with that impaired epidermal barrier. And unfortunately, Staph aureus also seems to induce production of pro-inflammatory cytokines. So it can drive that flare. And it's important to recognize that, because it's often a lot harder to get a flare under control if you're not addressing any concern for staph colonization in addition to your anti-inflammatory treatment strategy. So group A strep, less common, but can be seen, and I always recommend treating that orally. And cultures are really helpful in determining what's going on and what the causative organism. And if you're really worried about an infection, I think it's mandatory to get a bacterial culture, and that can help you confirm your diagnosis, identify the causative agent, and then that can help guide your antibiotic therapy, especially in an age where resistance patterns are hard to predict, and we see a lot of unusual resistance patterns to common antibiotics that you would use for Staphylococcus aureus infections. Next slide, please. So I tend to recommend using mupirocin ointment, at least as sort of first line over things like bacitracin. It seems to be more effective. And I tend to use it if there are areas where there are erosions and crusting and real significant disruption of that barrier. We're just trying to minimize the likelihood of getting a true skin and soft tissue infection in those areas. And then again, doing some sort of antibacterial wash type procedure, it can be helpful, but really only if you have a child who has frequent problems with infection or they always seem to be colonized and you're trying to minimize the bacterial burden on their skin. We're not really removing all of the bacteria, but we're just decreasing it to a level where hopefully it's less of a problem. And so some of the common things that you can use, bleach baths or swimming in a chlorinated pool can be helpful a few times a week. There is a commercial product called Clean Wash, which is sodium hypochlorite based, a little bit more elegant than Clorox. Chlorhexidine gluconate cleanser is available, although in my opinion, I think it can be irritating for some people with atopic dermatitis. Benzoyl peroxide is over the counter, usually seen as an acne wash, but a really good general antibacterial agent, although it can also be a little bit drying. And so those are some of the strategies that we tend to use if we're worried about frequent infection or colonization. Next slide, please. So here's a child with some hand eczema and a cellulitis that was positive on culture for Staph aureus. Next slide. Looks pretty painful. Here's a child who had group A strep. So a little bit less well-defined erythema, but it was warm, it was tender. The degree of eczema in that area is actually, not too bad, but the other skin findings were pretty dramatic. So culture was very helpful there. Next slide, please. So we'll move into viral infections. So Eczema Herpeticum, the classic presentation are those grouped and punched out erosions. They often tend to favor areas where the child tends to flare. In particular, with an initial presentation, there may be fever and malaise and some other symptoms going on. It's fairly straightforward to confirm the diagnosis with a swab from an affected area sent for a PCR. You do have to be fairly vigorous when you're swabbing. You really want to get down to the sort of moist skin under any crusting, because that's where you're going to find the epithelial cells that are infected with the HSV. So you have to be fairly aggressive with that. And in general, for extensive disease, for children who are ill appearing, if it's worsening, if they're immune compromised, it's usually recommended to initiate oral antiviral therapy. And then for those children who unfortunately are developing frequent flares, they do sometimes need to be placed on suppressive therapy. Next slide. So here's a typical example of Eczema Herpeticum. Up close, I think you can appreciate all those sort of monomorphous, coalescing, punched out erosions. And there may be a secondary bacterial infection too, so it's always helpful to evaluate for that. And the classic location for eczema flares in that intercubital fossa and the flexural aspect of the arm. Next slide, please. So other viral infections, molluscum, fairly common in children with atopic dermatitis. It does tend to favor the areas where the flares are, probably because there's auto-inoculation going on. It can also trigger flares of atopic dermatitis as it's revving up the skin immune system. So they're often seen together fairly frequently. And I do always exercise caution with use of certain off-label treatments for molluscum, such as topical retinoids, because they can be quite irritating, and that can unfortunately then flare the atopic dermatitis, and then that can increase the likelihood of the molluscum spreading too. So have to be a little bit careful with that. And then Coxsackie virus, so Eczema coxsaccicum, as apparently we call it these days. You can see this luckily is self-limiting, but sometimes it can mimic Eczema herpeticum or other skin conditions. You can confirm the diagnosis fairly readily with a skin swab sent for enterovirus PCR, as long as you have a lab that's willing to perform it. And sometimes it's helpful to confirm that diagnosis so you don't have to worry about some of those other conditions. Next slide, please. And then, oh, so molluscum, so there we go. A little hard to see, but I tried to point out where some of the molluscum are, and then you can see that that child has an eczematous dermatitis, around the molluscum, pretty classic location on the popliteal fossa as well. Next slide, please. So fungal infections, pretty uncommon, but again, as I mentioned, there seems to be some evidence that some patients with atopic dermatitis do seem to be sensitized to Malassezia. Malassezia is a common organism. It's considered normal skin microflora, but in some people, it seems to trigger this marked inflammatory reaction. And then that, unfortunately, can trigger flares of atopic dermatitis. It seems to more commonly affect areas like the head and the neck. Malassezia is often common in the scalp, and that's probably at least partially why. You cannot culture Malassezia, unfortunately. You sometimes get lucky and you can see it on skin scrapings from the affected area if you have the ability to examine them under light microscopy with potassium hydroxide. But often it's just an empiric diagnosis, an initiation of topical antifungal therapy, oftentimes an azole agent, or occasionally for mild disease, some over-the-counter zinc parathione-based agents can be helpful too. So uncommon, but something to think about if you have someone who's flaring and you can't figure out why. Next slide, please. So the atopic march will kind of segue, and I think everybody has heard about this concept that this epidermal barrier dysfunction that you can see early in life, with or without eczema, tends to predispose to sensitization to allergens from the environment or from foods, and then that can increase the likelihood of developing other atopic conditions like asthma, allergic rhinitis, food allergy. There's some other components to that theory, but from the standpoint of atopic dermatitis, there is thought that it can be helpful to make sure that you're really managing their skin disease as well as possible. It often is of the first atopic disease that presents, and this is done in the hopes that you're minimizing the likelihood of development of other atopic disorders. Next slide, please. So food allergy is certainly a hot topic these days, and I think that it is important to stress that we really don't recommend using elimination diets or hydrolyzed formulas as part of your general management strategy for atopic dermatitis. They're rarely, if ever, indicated. There's some other concerns with using them. Similarly, we don't really recommend screening for food allergy by using serum-specific IgE antibody testing. These are difficult tests to interpret sometimes, and we don't want to unnecessarily restrict, especially in infants, exposure to certain foods, because as we see with studies that are emerging, and particular, peanut allergy related studies, there's real concern that unnecessary restriction to foods during early infancy, when the child needs to develop immunotolerance to these things, can actually start to increase the risk for the development of IgE-mediated food allergy. So my recommendation is if you're worried about food allergy, probably best to refer that patient to an allergist who's experienced with pediatric atopic dermatitis and food allergy, and they can decide for further evaluation and management strategies. Next slide. So I think everyone's probably familiar with the LEAP study, learning about early peanut allergy study, in which it was shown that infants with mild to moderate atopic dermatitis who were introduced to peanuts early in life had a significantly decreased likelihood of developing peanut allergy by age 5. So the recommendations now are fairly clear with regards to introducing peanuts in susceptible infants who have atopic dermatitis. Next slide. So I think everyone's familiar with these, so I won't belabor them, but basically you're stratifying infants into no eczema or history of food allergy, mild to moderate eczema, and then severe eczema, with or without egg allergy. And for your milder to moderate disease eczema patients, it's recommended that you just introduce peanut-containing foods, around 6 months of age. And if there's no eczema, obviously you can do that in accordance with family preferences. But there's lots of well-published guidelines on how to do that. For children with more severe eczema, and again, I think that sort of comes back to being comfortable with that IgA scale, those are the children for whom it's probably reasonable to refer them to an allergist and let the allergist help to decide what the best way is to approach that issue. Some of them will do serum-specific IgE testing or skin prick testing. Some will just do an oral food challenge. But that's probably the best approach with regards to that. And that should be done fairly early. You want these kids to be eating peanuts at a pretty early age. Next slide, please. So a couple of other concerns with regards to comorbidities. So we talked about steroid-related atrophy. Excuse me. Other steroid-related diseases can include Cushing's disease, iatrogenic Cushing's disease, suppression of the HPA axis. These are fairly uncommon with use of topical corticosteroids as opposed to systemic corticosteroids. Many children can develop sleep issues, behavioral issues, mood disorders, issues with poor quality of life and poor school performance. I think these will be touched on a little bit later. And then alopecia areata, interestingly, is associated with atopic dermatitis as well. So just something to think about there. Next slide, please. So adherence, I'm not going to belabor this, but adherence is probably, again, the largest factor that plays into poor outcomes with atopic dermatitis. And there are many reasons for this, obviously. Some of the ones that I see include perceived lack of efficacy of the treatment. So again, that helps us to emphasize the importance of setting appropriate expectations, concerns about medication safety, corticosteroid phobia, or concerns about other medications. So we always want to make sure we address that. Limiting the use of topical corticosteroids inappropriately. So we don't want to stop too soon, and we don't want parents to stop too soon. Treatments can be messy and take time and be expensive. And so it's important to suss out what's going on so we can provide a treatment regimen that we think the child will actually use. And the older the child gets and the more responsibility that they take for their own skincare, the more likely these factors are important. And then instructions, need to be clear and not terribly complicated. That's where that eczema action plan comes into play. Next slide, please. I try to assess adherence at every visit, and for sure, if I don't feel like the disease is well controlled, you'll be surprised sometimes at what you'll learn if you ask the right questions. And if I'm really struggling, if I'm having issues figuring out how to manage adherence issues, I always recommend referring to a clinical psychologist or other mental health provider who has expertise in management of chronic illness and adherence, and even better if they're familiar with dealing with atopic dermatitis, just so they're familiar with some of the nuances of skincare and the recommendations that we make. And it can be immensely helpful to do that when children and families are really struggling. Next slide, please. Okay, a couple clinical pearls and I think we're done. So some of my highlights, next slide. So remember, when you see hypopigmentation in the skin in association with atopic dermatitis, it's usually post-inflammatory. And we're coming into summer now, so tanning of unaffected skin around areas of atopic dermatitis can accentuate these areas of hypopigmentation, make them look more noticeable, but this is a benign phenomena and it's not due to the steroids. And once you get the eczema under control, then you should notice that this will resolve. Next slide. Think of infection when there's a flare. I do always recommend doing cultures. So if you do think that an oral antibiotic is necessary, you know what you're treating and what the best treatment is. But usually some sort of topical antibacterial therapy is appropriate for most children. Next slide. Ensure that your patients are always putting their medications on first before the moisturizer. And ideally they're waiting a little bit of time if they can, so the medication has some time to be absorbed. If you put the moisturizer on first and then the medication, it's a little bit harder for that medicine to get where it needs to go. So always medicine first. Next slide, please. We talked about atrophy, so don't be afraid to use steroids. Just make sure that you're monitoring. Atrophy doesn't happen overnight. It definitely takes some time. So if you're worried somebody might be at risk, it might just mean that you need to follow them a little bit more closely up front to make sure that they're using their medications appropriately and you're not starting to see signs of concern. Next slide, please. Allergy-related clinical pearls. So again, I don't usually recommend doing serum-specific IgE screening or elimination diets. If you're worried about it, I always just say send them to an allergist who's knowledgeable in that area, and let them evaluate and manage that as appropriate. Next slide, please. And then adherence. Again, can't stress that enough. It's really, really, really important, especially in children who are not doing well or who have more complicated disease, to make sure that you understand whether they are adherent, and if they're not, that you're helping to figure out why, so you can address that and then put that child and that family on the right path. Next slide, please. A couple references, just some great reviews, I think, about management of atopic dermatitis in children. And then I did put the reference up there for the LEAP study too. Next slide.
Okay.
So time for questions.
And Dr. Shaw, there's already a few questions in the chat box, so I can read them to you if that's okay.
Okay, sure. I got it up there too, so.
Oh, perfect. Okay. So you mentioned that creams are your favorite. I sometimes find it hard to use creams for larger areas. Do you have recommendations on using lotions over creams for larger areas?
Yeah, I got to say, I'm not a lotion fan. I think some of the issues with using creams are that people over apply them. So they're trying to use too much, or they're trying to take a big glob and start in one place and then smear it everywhere, and that approach doesn't work so well. So that approach of taking small amounts, getting them in their general areas and then rubbing them in seems to work reasonably well. If you put the moisturizers on after bath time, when the skin is still a little bit damp, that will help to thin things out a little bit too. And so I think that makes them a little bit more tolerable. Or you can add a little bit of water to them to thin them out if you absolutely need to. But I find that most of the time it's an application technique problem, and we can usually sort through that, by making some simple suggestions there. But I think the lotions just, unfortunately, they just don't hydrate the skin enough. For all but maybe the mildest disease, I think there are probably better options out there.
And then, are there any creams covered on Ohio Medicaid?
No, so I don't think Ohio Medicaid covers any general moisturizers anymore, unfortunately, as of earlier this year, which is hard. It's a real struggle, unfortunately. There's no easy answer to that other than to just make sure that families understand, how important that is, and that they make use of, resources that might be available, sales and promotions and shopping different places and doing price comparisons. There are always sales on at different drugstores, buy one, get one free, or different discounts and things. And so I think it just requires a little creativity, unfortunately. But it's a problem that we have as well, and we've actually brought that up numerous times to people who we think may be able to help us, but I'm not sure that's going to change anytime soon, unfortunately.
Okay, let's see. What is the highest potency topical corticosteroid you would be comfortable with a PCP using?
So I think it depends on the age of the child, the location that you're treating, and the disease severity. So for most infants, let's say, most of the time they can be managed with your, low potency class 7, to lower mid potency class 6, class 5 agents. It would be pretty uncommon to have to use something stronger than that. Your school age children, you may be able to, or you may need to use, occasionally a class 4 or class 3. Don't usually go too much higher than that. Adolescents rarely, might use a class 1 or class 2, but for very short periods of time, and only under pretty close monitoring. Unfortunately, we do see patients sometimes who have been prescribed a potent topical steroid in large quantity, and they just kind of go to town with it, and they, don't come in for follow-up, and suddenly a year later they come back and they have some striae. So it's not so much that you can't use them, but you just really have to make sure that you're following and monitoring very closely. So my preference is, use only as strong as you need to, and back off as things get better, just to minimize those risks.
What about the LEAP guidelines for infants? Infants with severe eczema or egg allergy recommended to receive peanut-specific testing. What counts as severe eczema? And is there a template for step care plan for eczema?
So with regards to the LEAP study, so I think trying to determine whether eczema is severe, I kind of go back to the IGA scale. I think that's what's helpful in my mind. So those children who really have fairly widespread disease, there's really marked erythema, there's a lot of induration or like henification, cresting, scaling. So just kind of going back to that as the basics can help to stratify who's severe in terms of the eczema. In terms of step care plan, I'm not sure I fully understand the question. There's certainly, to my knowledge, isn't a simple template that applies to everybody with regards to how to manage things. I think you have to start with ascertaining disease severity, and then being comfortable with certain strengths of topical steroids and age indications for non-corticosteroid agents, and making sure that your patients are using them appropriately, you're giving them enough time to work, but not too much, and you're really following them closely. So I typically bring a patient back within 4 to 6 weeks after an initial visit, if they have mild to moderate disease, to see how things are going. I may need to see them every 4 to 6 weeks until I feel like we have a good plan in place. And I might be going up a little on the strength or down on the strength or changing this or changing that. I think it's definitely a nuanced strategy. There's unfortunately no kind of one fits all, but the more patients that you manage with a similar sort of approach, I think the more comfortable you get, and then you kind of make your own template, if that makes sense.
Great. So we'll do one more question now, and then we'll take a 5-minute break, and Dr. Shaw can answer the rest of the questions via the chat box or at the end of the training if we have time as well. So one more question is medicine first, then 30 minutes after bath?
Yep. So usually on bath days, I think doing medicine after bath as one of your applications is helpful. So you kind of get them out of the bath. You should briefly, blot off, the drippy water, but you can leave the skin a little damp. Medicine goes on where medicine needs to go. If most of the skin is ineffective, I think it's helpful to kind of moisturize the other areas. Then if you can, come back in 30 minutes or so and make sure they're really getting moisturized either everywhere again or just the spots where you had to put the medication. If it's not bath time, then, you're putting medicine on where it needs to go, and then coming back, within 30 minutes to kind of moisturize everywhere again.
Great. Okay, so we will take a 5-minute break, and then Dr. Harris will start presenting at 2:25. Thank you, Dr. Shaw.
Thank you.
And we will make sure that the rest of these questions are answered via either the chat box or if we have some time at the end of the training. Okay, Dr. Shaw, and if during the break you want to try to share your slides. Mm-hmm. Hopefully we can get it to work.
Yeah.
Okay, I can see it.
Great. I am hitting, there it goes. Yeah, is it working?
It hasn't came big yet to the screen. Maybe click enable editing at the top.
Oh, okay.
I don't know if that'll work, but oh, you did click through. Okay.
Yeah, I think,
Oh, it went away.
that's okay. Let's try again. I think it's just, there's a delay in the sharing
Yes.
speed. Okay, does that work?
Yeah, I can see the atopic is antagonizing.
Okay, yeah, I think there's just a delay, so I'm going to leave mine up if that's okay.
Yeah, that's great.
Good.
There we go. We're ready to go.
So hard not to talk to people.
And if there are any other questions during this time, you can go ahead and put those in the chat box and we will make sure that they get answered throughout the presentation. Okay, we will go ahead and get started with Dr. Harris.
Hello, thank you for joining us and learning a lot about, or just refreshing a lot about the different ways to treat atopic dermatitis. And one of the more interesting, exciting parts about this is that we're learning more about how atopic dermatitis and mental health are intertwined, which speaks very well to my background. So I'm excited to be here. We're going to talk about common problems associated with atopic dermatitis, understand and practice developmentally informed solutions. Several people had asked for tips or tricks on how to help people when they're having trouble with adherence, and then pretty much practice like how a practice could do medication adherence and understand the principles. And so I don't know if you guys can see this part. Basically, atopic dermatitis is antagonizing. So it's like the itch that rashes, and I'll explain a little bit about how that happens. And it can go from itching to scratching to rashing to ouch, it hurts when you have like an infection, and then stress associated with it, which actually further exacerbates. So this is like the itch stress cycle. So one of the really fun ways that the British Medical Journal explained atopic dermatitis in 2018, they talked about it having like a psychodermatology. And we all know about environmental triggers like irritants and wool and chemicals that can affect the cycle to happen or the flare to happen with atopic dermatitis. But we're going to talk a little bit about how psychosocial and maternal child attachment can affect an outbreak of atopic dermatitis, as well as individuals' emotional stress can lead to a cascade that would result in a flare of atopic dermatitis, if not exacerbate it. So we have a stress to the body, and whether it's like a mechanical irritation or injury or an emotional one, we have like a release of stress hormones or neuroendocrine mediators. And they release these cytokines into the system, and there's cutaneous cytokines that happen. They release IgE. They also release they decrease the barrier proteins that make up the surface of the skin, as well as the antimicrobial peptides are kind of suppressed during this process. And it leads to endogenous glucocorticoids, which kind of shifts the helper T cells toward the allergic response. And with T helper 2s is like what strikes the pruritus initiates pruritus. And because of the antimicrobial properties being suppressed, we have an increased risk of infection. And even with the chronic, and Dr. Shah mentioned before, one of the interleukin 22s, not that anybody's going to remember this, but one of the T helper cells actually is what contributes, they've narrowed it down to the single one, IL-22, that contributes to lichenification and that epidermal hyperplasia pattern that happens. So simply, eczema can flare because of stress happening. It either exacerbates it or precipitates it. You can have itching, and you can have problems with it. You can have like how your skin looks, how it feels. You can have secondary psychological problems from it. And we actually have noticed that people with eczema have a higher likelihood of certain mental health disorders as well. We'll get to that in a minute. So just a little bit more about why this happens. And if you'll remember that fight or flight pathway with the neuroendocrine system again, there's this activation of these cytokines in the inflammation process, but it also, you have increased cognitive arousal, mobilization of fuel sources. So, the gut stops digesting and the energy starts going to the muscles and the brain, and it triggers this fight or flight. So like atopic dermatitis flares can cause stress, and emotional stress can cause atopic dermatitis flares. So if you're finding a family is, adherent with everything and they're doing all the things they say they're doing, just start thinking outside the box about what else could be going on. This could really lead to what could be helpful to stop or minimize the flare that's happening at the time. So there's a strong relationship between ADHD and atopic dermatitis. Alone, based on one of the national health studies, child health studies with like 20,000, I think it's actually 40,000 people, they found that atopic dermatitis alone probably accounted for about 10% of the ADHD diagnoses that were given. As you remember, the idea of cognitive arousal, so these kids are like, easily distractible because they're hyper alert. They have lots of energy, they're bouncing off the ceiling, they can be very disruptive, they have this fight or flight, they could get really angry and grouchy, and often they're oppositional or attention deficit disorder, and they may actually have both, but it's definitely when they treated the atopic dermatitis, the ADHD improved. So for controlling for ADHD, even despite that, there still was a higher prevalence of anxiety in families with atopic dermatitis. sleep was the one modifiable risk factor and mediator really of both ADHD and atopic dermatitis, but it even modified the relationship, and it probably dealt with inadequate sleep alone wasn't the issue, but that actually pro-inflammatory cytokines that are released in anxiety and depression were also seen in atopic dermatitis, and which would disrupt sleep even further. So there's definitely a correlation between sleep and atopic dermatitis. Of the skin conditions, kids reported that of everything, they had like more common skin conditions like psoriasis and everything. And we mentioned the Molluscum Contagiosum and even acne. Atopic dermatitis had the largest impact on quality of life. And they talked about sleep disturbance, daytime fatigue, and mood problems as being the most commonly listed issues associated with atopic dermatitis. So big things that you have to remember with it, it messes up your sleep and it makes you itch, and the itch messes up your sleep and the sleep messes up everything if you're not getting good sleep. So as a true psychiatrist, everybody needs sleep. You need to reset your brain, and if there's disruptions in sleep, nobody's doing okay. So making sure, especially with parents who are managing children who are waking up frequently scratching, or perhaps the parent is being woken up by the child scratching who's sound asleep, that disruption in sleep is going to affect that caregiver, and it's going to affect the child. It's going to affect that parent-child bond, and it's a pretty important piece to consider. And while it is like just skin, it's actually a pretty important part of that maternal-child bond. So it's interesting how even when your kids had regular atopic dermatitis, 60% of them had impaired sleep. And if they were in a flare, this is just like generally 60%, but if they had a flare, it went up to 83% of kids having problems sleeping. Often they were woken up by itching. So itching has the highest impact, and I think Dr. Shaw mentioned that earlier, has the highest impact on quality of life, and it's the most disabling. So the best thing you can do as a pediatrician is to control the itching. And it's more of a problem for school-age children. They seem to be more sensitive to it. And I was trying to find, but I didn't know if I had the right copyrights, but if anybody has children with The Secret Life of Pets 2, the main character, Max, develops a stress response of scratching himself when he gets stressed out. And it's a very great, perfect way to show kids the connection of this is what happens when you get stressed and you start itching more. I was impressed with, I think it's Pixar who brought that forward, so yay. So thinking about it from a developmental perspective, so really, as I was saying before, that 0 to 3-year-old infant-child bond or infant-parent bond or caregiver bond is so important. And you can get to parental exhaustion, clinginess, fussiness. For kids 0 to 4 on the quality of life surveys that they were doing, they had negative effects on mood, like parents described them as grouchy, fussy. They had trouble controlling itch, problems with the treatments, applying them. The security of the maternal-child bond was affected, which is a pretty big deal in terms of developing your sense of self-worth, esteem, your safety, your circle of safety is affected when a parent can't console a crying baby. Like that's a very distressing thing for a parent or a caregiver. And it's really kind of our job to help them learn that, prevention is key, and really applying the good preventive measures that are going to be the most helpful. But then if they are having a flare, if the child's having a flare, it's extremely important to treat the itch and to treat the actual disease and get the flare down as quickly as possible. For school-age kids, they're often, starting to understand differences about each other. So they're going to be more likely to be influenced by teasing and bullying. Second grade is one of those classic ages. Now it's even first grade, really, where they learn differences and they learn the power of their words. So teasing and bullying, but not really fully understanding the impact that it can have on other people, happens quite a bit. So atopic dermatitis is one of those visibly different differences, and it can make a big deal. It can make something that's, a pretty benign condition into a very big deal to a kid. Good news, this is why I work with kids. Most kids are optimistic and that they can get through this. Some kids actually do have anxiety and depression, which is worsened by the atopic dermatitis. So as Dr. Shaw mentioned, this is, it can be chronic, and she showed some pictures of some pretty chronic, extensive atopic dermatitis in adults. And there appears to be an inherited hypothalamic deficiency in the HPA axis, which, you know, as I was reading through, like the cutaneous neuropeptides, the ones in your skin released, may also mediate the neurogenic inflammation. So this mast cell degranulation. So that really, you know, allergic response on the skin, and it's just kind of chronic in that epidermal hyperplasia that can happen to, not just in adults, but that can happen in kids. But there is increased undiagnosed anxiety and depression in adults. So if you notice the child is having a lot of problems, the parent also has atopic dermatitis. If they're, you know, not really interested, they're hard to engage, difficulty treating, very kind of nothing works, everything's negative, like really think about some underlying mental health issues. If there's any anxiety or depression going on, psychosocial stressors, you know, are they able to afford things? We'll go through some of the problems that can happen, or reasons why people aren't following through, but just be aware that mental health is an extremely important part of the assessment of persistent atopic dermatitis. Okay, so let's talk about how do you get to some of those answers and how do you improve quality of life. So many factors, and this is part of our campaign here is, you know, in just kind of in pictorial form, some of the ways to remind you that reasons why treatments fail. And, you know, we can talk about nutrition and possible food allergies. Simplifying the medication regimen helps. But really the most important thing that parents appreciated was a structured intervention where it reduced how much they had to think, as well as more time with professionals, understanding and having education. So primary care role, and this is pretty much for everything, but we're going to apply it to atopic dermatitis, is breaking it down into simple things to remember. You assess the problem, not just the way you see the problem, but the way the parent and the child sees the problem. You validate the struggle. This is a communication skill that will actually have people listen to you more if you're going to offer education. You know, you make sure you understand the problem before you try and solve it. Normalize the process, whether it's developmental issues, whether, you know, nobody is 100% with it. You know, we're going to go for good, not perfect, depending on how much the other competing strategies and competing struggles there are. Kind of meet the family where they are, help them move one step forward, and really help them prioritize what would be, if you could only do one thing, I would recommend that you do this. Or, you know, if there's 5 things that you see, which one do you think will be the most important or the most possible for you to do? So kids come in, it's not working. Parent comes in, it's not working. So again, assessing the problem, and making sure you have the right diagnosis. Do they even understand atopic dermatitis? I've had many families come in and say, I put the cream on, it went away, now it's back, so that didn't work. So basically understanding like what their knowledge is of it and their understanding of what are the triggers, what are the basic principles of atopic dermatitis. Are they even getting the appropriate treatment? Is there anything else going on that could be causing stress? Because stress can make it worse. Stress could be, you know, food allergy, it could be environmental, but it also could be emotional stress. So validating the struggle. Usually we ask, especially when we're talking about adherence, you know, are you taking your steroids? Didn't you do what I told you to do? Kind of that parental tone. And parents, kids, caregivers, we're smart. It's, they're going to give you this socially desirable answer, and they're going to pretty much essentially give lip service a lot. Like, oh yeah, I used all the creams, I did everything right, blah, blah, blah. But when they bring in the tubes, and I know Dr. Tashi has the families just bring in everything that they have at home, that's when you can really see what they're actually getting through and what's actually happening. You can do electronic monitoring, but it's really not as effective as asking the person themselves and really shifting kind of the culture of questioning to, you know, you just have to talk to them a little bit differently to get actual accurate results or accurate answers. You know, what about this is bothering you? Like, what would you like to see get better? You know, one of my favorites is like, how many times or how long can you go without applying your cream before you really get into trouble? And that one often gives me an idea of if the kid has even tried, or if they have one of those benefits of anxiety, we're like, oh no, I don't miss any time. You know, that's one of the great ways to channel anxiety for good. But, you know, really asking like what's getting in the way. So here's a problem. This is what you want to see get better. What is getting in the way? And you really have to understand that before you can help them fix it. One of the things to kind of keep in mind is with the adolescents, and they're really developing the sense of autonomy and self-responsibility and self-reliance and kind of who they are as a person. Sometimes they don't want to be bothered with it, but kids that had more of a positive or characteristics of a teen where they had a more positive outcome, where if they had positive family functioning, so the emotional stress at home was not as difficult, they felt like they were in control. So there was something that they could do to make it better or worse. If they're able to kind of have those connections with people, usually depression would pull away from that social withdrawal happens with it. You know, having an immediate benefit from treatment. So if they have to wait weeks and weeks, it's not as helpful. And basically, if the patient thinks it's a problem, so that goes back to the, you know, assessing the problem, like what do you see as the problem? What do you want to see get better? It may have nothing to do with atopic dermatitis. And until you address the distress, the teen is going to have a hard time hearing you. So making sure that you as the physician or clinician taking care of the child is very empathic will go an incredibly long way. And that alone is therapeutic. But we're going to, things that, you know, obviously are not very counterintuitive, but just worth mentioning, you know, stress, family conflict, having a really complicated regimen, like on, you know, Monday, Wednesday, Friday, you do this cream and this, you wait 5, you do this, you do that. And then, you know, if it's on the face, this is what you use. And if it's on the skin or on the hands, and then this is for the body. And I don't know if you guys have seen some of these tubes, but they're really complicated names and very tiny written on the tubes. And it can be really, if your kid is screaming and crying, like, and they're itching, you know, it's hard to remember. It's hard to remember to even go back to that paper. So just really kind of making sure that you keep things as simple as possible for families would be great. Developmentally, thinking about where the kid is developed within their developmental trajectory. I'm going to get to that in a minute. You know, sometimes concrete to abstract. I think the most difficult patients and challenging ones I have are the tweens, where they're still in that concrete conceptualization of the world. They're getting some abstract. They can abstract a little bit, but not enough that we would need for really like the adolescent thinking when it happens. So sometimes they're answering your question, but they're really answering it for this particular moment in time, not really over the past few days. So making sure that you are appropriate with how you're assessing the kid is critical to questions. And if the parents don't think it's a big deal, it's going to be hard to fix it. So as I said before, you know, a structured intervention and more time. And they compared dermatologists to nurse practitioners, and this is nothing, Dr. Shaw is completely different, but you know, they mentioned that, but really it was the amount of time you spent with the family is what contributed to the kids getting better the best. And when they were able to follow up every 2 weeks, which dermatologists really can't do, it's the, you know, nurse practitioners or the physician's assistants or someone else who has the ability to bring the kids back and do a lot of education. Those families are the ones that tended to do better in the long-term outcomes. And, you know, sometimes you can do that, sometimes you can't. Even just honestly offering that information is very validating for the struggle if they're having trouble doing it and getting there. We're gonna hopefully talk a little bit about Eczema Action Plan. Dr. Shaw mentioned some key principles, but kind of start thinking about what might need to go into your Eczema Action Plan. So the third element is really helping them prioritize. So if you have to decide between, you know, what kind of soap to buy, what to pick up at the pharmacy, or what foods to avoid, depending on the patient, it's really going to be specific to the family and individual to the family, even how long they bathe. You know, depends on many different things. So, you know, whether the parent understands, if you have the right diagnosis, like if they're hypersensitive to things, you know, the skin infections, you really have to help them pick, or you have to pick first, like what do you think is the most important issue that they're describing once you understand the problem, and then, you know, kind of approach it from these boxes of, you know, what do I need to do to get to my goal, which is helping the kid remain flare free. So you're going to practice your own problem solving. So what works, this is kind of the basic tenets. We know this, prevention. So avoiding the triggers, improving your skin barrier, especially in young babies. She was talking about that march, the atopic march, and looking at the, if you're able to kind of prevent the amount of flares of the infant early in life, there is theory that you could be reducing their hyperreactivity, their cytokine releases, their risk of developing asthma, the severity of asthma they develop, or even the risk of like allergic rhinitis or even, you know, food allergies. So the idea is like really these babies, keep them greasy as much as you can and get the skin barrier as healthy as you can. Johnson, I'm not trying to do anything with fragrance, is very, very drying. It has an ester alcohol, which is what makes it have the aroma. And that's usually a big sign that it's going to dry out the skin. So it's going to make it worse. All right. So we want to, if there is, you know, a kid's not doing better, think about anxiety. Anxiety, they will tell you, no, they're not anxious. But, you know, when I'm assessing anxiety, I never ask, are you anxious? Because everybody knows that the answer is no. Or if a kid's anxious, they have no idea they're anxious. So they're going to say no. But I would make it a more of a positive response is allowed. Like, are you good at worrying is my favorite question. And you often have a thought that gets stuck and it's really hard to get it out of your head, even if you're trying to do something fun. You know, things like that can really help you identify the kids that might have a problem with anxiety, because it might be normalized by the anxious parent as well. But it could be hypervigilance and that hyperarousal on the somatic system, which is kind of making the system even more ramped up. So kids with anxiety feel things more. And they also may be itching and scratching and not paying attention. So they're often, you know, labeled ADHD, but they could have comorbid ADHD, which makes it even worse for them to function at school. So really the idea is to improve the adherence to the plan. So we're going to talk about adherence. And this is actually information coming from a new colleague at our, in psychology, we have a department devoted to medication adherence. So because of this project, I was able to find them and work. And I work in a different department, psychiatry, but it was really great that this was available to us. So basically the medication adherence promotion principles, or actually the kind of the concept is that, you know, you educate families, ask for feedback, or you attain feedback about what they understood. You bring them back, you look for problems, work on problem solving and goal setting, like what do you want to see get better, and think about like social support. So with these like 5 pillars in place, it's really the core of what helps anyone adhere to the medication plan or the plan that we have set forward together with the family. So Dr. Shaw mentioned about managing expectations. So you want to make sure that they know it's a long-term thing and to define the problem. And really, you see the problem, you know the answer, you're the expert, but it really is up to the family what they see as the problem. And if you're really struggling and feel like you're getting stuck, like I've told you this 300 times, it's better to stop, listen, and make sure you're hearing what the actual problem is. So patient-centered is, you know, what bothers you about your atopic, you know, how it looks, it feels, how does it get in the way, and, you know, what's easy or hard to remember to do. And I usually say easy or hard at the same time. Again, if the kid has anxiety, they're going to give you the right answer. So this is a way for them to give a dichotomous answer without feeling like they're giving the wrong answer. And for a parent-centered approach, it's like, you know, what's your biggest concern? Is it the kid's not sleeping, you're not sleeping, they're super grouchy all the time, you know, they're not doing what I told them to, they should be able to do it by now, I have too many things to do, or it just costs too much. Like these are the ways that you can better understand like what's going on. So it's a specific technique that I'm gonna go through, and I think we're doing okay on time, perfect. So it's called problem solving, and it's applied to atopic dermatitis here, and it's simply a technique. So having, and depending on the family, whether it's you working with the school-age parent and the school-age child and the caregiver, or the teen themselves, really, if this is a teen that's going to be managing a lot of their things and the parent wants them to have this responsibility, I would literally direct it to the teen and, you know, ask them what the specific problem is. You know, what's happening that you'd like to see get better or stop. And it could even be, you know, my sister hits me when I scratch my arm to get me to stop, and I hate that. So that's the problem, literally what it is. As long as it's relating back to the atopic dermatitis, sometimes they need help focusing. That's what you write down in their words. Then it is like the patient generates 3 solutions. And then when they have those solutions to solve the problem, then it's how likely are those solutions going to solve the problem? And, what are some of the barriers that might get in the way? What are some of the, what is the one that's most likely going to help? And that can be a little bit tricky. You can definitely do this while you're doing your exam. It's more like a conversation. Okay, what do you want to try first? Okay, what else would you try if that doesn't work? All right, give me one more idea about what would solve that problem. Okay, of those 3, which one is more likely to get to your final goal? Okay, how likely are you to do it? Those are really the kind of the rhythm of asking about problem solving. Most important thing, do not pick the answer for the patient, especially for the teenager or the parent. It is more powerful for them to think through and decide which one they're going to choose. Make sure you write it down in the chart. They picked, applying the cream right after bath. Then that's what is the goal, and that's what you're going to focus on. Okay, how likely are you going to do this, and what are some ways we can do to help make you successful with this? And we'll see you back in a couple of weeks. So some of the ways you can guide, because we're like, I don't know, and a lot of kids often do that. And if this were an interactive audience, I'd be asking the audience for help. But thinking about what are ways to associate. So memory is association. So you want to associate it with a visual reminder, if that works for the person, like marking on a calendar, keeping the medication next to the toothbrushes or next to the bath soap on the table. Whether you have something visual. I think Dr. Shaw mentioned something about wrapping a color of a rubber band around the tube that you're supposed to use, like a red, yellow, green rubber band, or like tape around them to make sure that they know which one to grab. For every day being green, and when they're having some early symptoms, yellow, and when they're really uncomfortable, red. Could help be a way to strategize. Link it with your routine, as I said, brushing teeth, or putting it next to the towels that you grab for your shower. Technology reminders, we often say, put in your phone, put an alarm. However, over the long term, those have the lowest behavioral change associated with it. It's great in the moment. It might last for a day or 2, but really it doesn't create long-term behavior change in people. So really, like, other kids are going to be auditory learners. So the verbalizing the triggers, like actually having them say, okay, so if I'm not going to remember this stuff, what are going to be signs in my body that tell me I need to do something differently? So if I start to itch, that's going to be a sign that I need to start doing my cream. And if it starts to get a rash, then I'm going to be putting my steroid cream. If it starts to hurt, then I'm going to be calling the doctor and getting an assessment for an antibiotic over it, or applying the mupirocin. So just kind of like helping them develop skills around insight to their illness is tremendous. And just call it a day after that. Write down what you, just highlights of what you talked about so that you can follow up with it again. Because really this concept of responsibility with teens, they will try. And if you don't bring it up again, they're going to minimize that work that they did. So it's not going to be therapeutic for them at all. So really having accountability is tremendous with changing behavior. So if they know you're going to ask about it, it doesn't even matter if they do it 2 days beforehand. It is still better that they're doing it and they're trying. And that's what you dote all over, how great that was for them, that they tried, they got it, nice, they can do this. Really a motivating thing for kids, especially ones with low motivation, which is also hard. Kids that don't care, kids that don't want to. And honestly, you have to see, where is the problem? You might be totally missing where the kid's having the problem, and that's why they don't care about the atopic dermatitis, or they don't see how that relates to the atopic dermatitis. And perhaps talking to the parent would be a more effective strategy, but sometimes motivating the kid or the caregiver is what you need to do. So what do you want to see get better? Again, the same theme of the problem solving. And what they're currently doing, this is the motivational interviewing part, what they're currently doing, you acknowledge, you validate, and you ask, how's that working for you? And if it's working great, then there's no problem. And if they are like, okay, fine, it's not really working that well, staying up till 2 o'clock in the morning and not taking a shower but once a week, I'm dry and crusty and I have like a lot of itching and my friends don't want to sit next to me. Like, they'll be able to tell you what's wrong, especially teenagers. They love talking when you start listening. And, what's getting in the way? Is that more valuable in this situation than what the problem is that you're describing right now? Or just different techniques to handle low motivation. And then really the idea of, for somebody who's completely resistant, something that I often do is, okay, what will be your threshold that would tell you that you need to do something different? Or, how will you know when you need to change your plan? Are great ways to help activate problem solving and decision making within the family. So parents are going to have to constantly be adjusting their approach because it's infants. There's a very hands-on, it's up to the parent, they get it done and, move on. As the kid develops autonomy, which I think is the hardest part of parenting, when they get their own opinion that you did not give them, is the tough part. And then you have to kind of change your game, so to speak. And this just talks about the Erickson's initiation versus, guilt and shame and autonomy, really just kind of looking through them and seeing, where the kid is and, if they're developing their sense of self, like just kind of speak to that part, like, what do you want to see and how are you going to do this, kind of responses to it. And really intermittent checks, so that intermittent reinforcement is the most powerful reinforcement tool with behavior change. So having a scheduled every Friday we're going to look, then Thursday you're going to get the behavior. But if it's just randomly picking and choosing when you're watching or seeing, that's going to definitely increase the reliability of the behavior change. So basically, keep it simple. What's the problem? What do you want to see better? We're going to pick one thing. You're going to pick one thing. Help them prioritize. So if they're really stuck, if they want to work on the most intensive steroid cream, kind of help them, educate them, and offer, if we fix this, would you even get there at all? Or just help them work through it, what they want to do, or what's the most important thing out of the regimen that they need to focus on. And they get to choose. They get to choose if it's, they get to do the wet wraps, or they do the creams or ointments or what have you. So I'm going through. All right, so then this is what we were talking about, the action plan. We can talk about this later and future, but just this is the summary of, thinking about problems with atopic dermatitis. The itch stress, cycle stress can be external or internal. They have an increased risk of anxiety, ADHD, and depression as a result of their atopic dermatitis, and it can cause atopic dermatitis flares. And your role as a pediatrician is to address the distress. Thank you. I'm finished.
Next one, put up.
I think we're going to go on to Dr. Peltier's presentation.
Yep, Alex, if you want to pull my slides up, and I'll let you drive.
Getting it ready.
And while Alex is pulling those up, after my presentation, we will do a final Q&A. So if you have any questions for Emily or myself, or if you thought of anything for Kara from her first presentation of the afternoon, we'll have plenty of time to answer questions at the end. So I'm going to try to sort of bring it all home and together and really, Dr. Shaw and Dr. Harris are really the experts in this and did a fantastic job setting the stage and really giving you all the information that you need to know to be able to take care of patients with atopic dermatitis in your practice, and also to be successful for those of you that are going to do the quality improvement project with us. But so I just wanted to give a few tips from the perspective of a pediatrician in general practice, in independent practice, and how you can take some of the information and pearls that both Kara and Emily talked about and how you can sort of incorporate them into your daily flow in your practice. Next slide, Alex. So you saw a couple of these numbers at the very beginning when Kara began to talk that we know that atopic dermatitis is something we're going to see, right? About a little bit more than 1 out of every 10 kids we see in our office is going to be affected with atopic dermatitis. The vast majority, at least almost 2/3 of them, have mild disease. However, This was published in a study in pediatrics a few years ago. 85% of patients with mild disease are being referred to dermatologists and not being managed in primary care offices. So, hopefully with the information that Karen and Emily presented, you now have knowledge and confidence to be able to manage these patients with mild to moderate disease in our practice, because we can do this as general pediatricians. We should be doing this. I love my dermatology colleagues like Kara Shaw when I have something that is out of my comfort level or something that I'm not very comfortable treating or shouldn't be treating. This, when we're talking about mild to moderate atopic dermatitis, this is something that we should be comfortable treating and should be done in our primary care medical home. Next slide, Alex. So why is it important for atopic dermatitis to be sort of managed as much as possible in the primary care home? Well, it's just like everything else we do, right? Our patients and families, we know our patients and families best. We've been taking care of most of them since they were born. We already have that relationship with trust that is going to hopefully spark greater adherence to our treatment plans. Obviously, ease of access. I know Carol would love to see as many patients as she can, but she and other dermatologists in the state have limited access. They can only see so many patients. There are a lot more primary care pediatricians and family providers in the state than there are dermatologists. I can get my patients with atopic dermatitis in tomorrow, probably even later tonight if they needed to be seen. So ease of access is huge. And just like any other thing that we manage in primary care, we play a central role in managing our patients for regular follow-up, maintenance treatment, ongoing caregiver and patient education. And really, we can and should be the first line contact for flares and other issues related to atopic dermatitis. Next slide. So again, hearkening back to Kara's original presentation, successful management of children with atopic dermatitis really comes back to three things: making a correct diagnosis, setting appropriate treatment and outcome expectations and outlining that plan, and then, as Emily talked about, ensuring adherence and good follow-up. Next slide. A fantastic opportunity to interact with our families with atopic dermatitis is during those either infant well-child visits or when they're in school, those yearly well-child visits. So we should be asking our parents and patients about skin concerns at every well visit. It's a great opportunity to ask our parents, do you have any concerns about your child's skin? You can implement screening questions into the EMR protocol. So for your well-child check during review of systems for a well-child visit, you can have skin concerns and you can have a section to document skin care. Providing anticipatory guidance on skincare at all visits, whether it's talking about moisturizer, when to use topical steroids, questions about how often to bathe, those sorts of things. And then making sure that you capture the diagnosis of atopic dermatitis in your patient problem list so that you have an easy way to identify those families and search. I mean, ideally, again, this is a chronic remitting diagnosis. So we should be seeing these patients on an every 3 to 6 month basis to check in with them and see how they're doing. If we capture those diagnoses in our problem list, it's going to be very easy, if your EMR allows it, to pull up recall lists and to schedule and get those patients into your office. Next slide. History, again, I don't want to repeat all of Kara's presentation, but just some highlights from a primary care perspective, asking about skincare regimens. What makes their atopic dermatitis better or worse? What is working for their symptoms and what isn't? Going back to Emily's presentation, asking about sleep, mood, anxiety concerns. If they're in school, how's their school performance and peer relationships? Considering using a quality of life tool for your patients with atopic dermatitis to qualitatively and quantitatively measure how their disease is affecting their quality of life. Confirm that parents and patients have been following the treatment plan. And then specifically, as Emily mentioned, ask about barriers to adherence. Next slide. If your EMR has photo import ability. You can import pictures of their skin lesions and their rashes into the EMR. Of course, you want to get consent to do that. But it's a great way to follow up, especially those kids that maybe come in with severe disease. You document the photo, they come back, you have something to compare it to, especially if you're not the one that primarily sees them back, if maybe one of your partners sees them back. So it's a great way to document disease progression and improvement, besides just relying on talking to the families to get their opinion. Next slide. And then treatment. Provide written treatment plans and confirm parental patient understanding. Keep it simple. Ask the families what they want to prioritize and what's important to them. If it's a busy day and you don't have time to discuss skincare regimens, train one of your nurses to do that in your office. Have the nursing staff discuss skincare and provide handouts that you've created or that you have found. Implement shared decision-making, and then schedule regular follow-up visits to monitor and ensure adherence. This can be a great use of telehealth. Sometimes, depending on lighting, Wi-Fi coverage, trying to look at rashes in using telehealth can be difficult, but it can be done. And also, maybe not even looking necessarily at the rash, but a check-in in maybe a few days just to have a telehealth visit with the family to discuss how is adherence going? What struggles are you having? What questions do you have? So it's a great use of telehealth, as many of us have been using more telehealth due to COVID-19. Then have your office do regular recalls. When you're seeing a patient in your office, be it a well child visit or for a flare-up, having a follow-up task that goes to your front office, asking the front office to schedule a follow-up visit in 3 months or 6 months, depending on what you feel is appropriate. And then, of course, for those patients that have more severe disease that you need some guidance from dermatologists like Dr. Shaw, develop relationships with your local dermatologist for when you need help or to figure out when is the best time to refer those patients. Next slide. I've just included this. This is a great reference. It's from Pediatrics from about 5 years ago, and it really looks at treatment and management of atopic dermatitis for primary care providers. And I've included the URL link as well as the full reference. Next page. And then this doesn't show up great, but this is a graphic that's in that article that really, I think, sort of summarizes sort of that nice flow sheet of going from acute treatment back down to basic management and back and forth for both mild disease on the left and then moderate to severe disease on the right. So it's a nice sort of very simple graphic that can help you as you're looking to manage these patients. Next slide. All right. So you all have been very patient for the last 2 hours listening to us talk. So I wanted to activate you all and get you a little bit involved in this presentation. So I'm kind of to tie everything up. And before I go into some of what the QI program is going to look like that we're going to be launching on July 1st, I wanted to sort of do a case review that will hopefully sort of summarize and emphasize the points that Dr. Shaw and Dr. Harris made during their presentations. So next slide, Alex. Okay, so you are seeing a patient whose initials are AD, who is a previously healthy white male who comes to your office accompanied by his mom for a 6-month well child visit. He has no significant past medical history. He does have a 3-year-old sister that you've diagnosed with mild persistent asthma. He lives at home with his mother and father and the sister. Mom, when you ask mom if she has any concerns today about AD, she says that she's concerned about a rash that he's had for about the past month. Mom has tried an over-the-counter lotion without any relief, and she's really unable to recall specifically what that lotion was. From an anthropomorphic standpoint, AD's growing well. He's got normal weight, length, and head circumference. He's on a cow's milk-based formula and has been eating rice cereal for the past 2 months, and his developmental milestones are on track. Alex, next slide, please. His physical examination is normal, except for an erythematous macular papular rash with some xerosis on his extensor arms. And next slide, we'll see a picture there. Next slide, Alex. So we are going to see how we can do this. So I want you to think about the patient's diagnosis is most consistent with number 1, tinea corporis, number 2, scabies, number 3, atopic dermatitis, number 4, psoriasis, or number 5, lichen sclerosis. And Alex, I'm going to have you jump in and walk them through how they're going to participate.
Okay, so I launched the poll. Can you see it on your screen?
I can.
Perfect. So now you can answer which question you think is correct. And when I end the poll, we will be able to see which answers people were more likely to select.
And I think we said we're going to give about 25 seconds, right, Alex?
Yes, about 25 seconds. So go ahead and start answering the question.
So choose what you think is the most appropriate answer and hit submit. And we're seeing a comment from somebody that they are not seeing the poll.
Can everyone else see it, or is it just one person? Oh.
You might want to be, I maybe make a recommendation to be in full screen.
Okay.
And someone could see it, so good. So obviously, if you're listening on the phone and not having access to the computer, you won't be able to see it. And we will go over the answers.
Okay, so if you could select now and answer, and then I will end the poll. Oh. And it doesn't look like anyone answered. That might be trouble on my end.
Okay, well, that's all right. I mean, we can just kind of go through this. We can, you know what, let's do this. Why don't we go ahead and go to the next slide? I think most people, hopefully, knew that the correct answer. Oh, Sarah's saying, oh, we do have some people that answered. So we are having some technical difficulties trying to figure out how to aggregate that. But of course, the correct answer was atopic dermatitis. So hopefully that was pretty obvious. And in fact, that was a slide that a picture was a slide that I stole from Dr. Shaw's earlier presentation. Okay, let's go on to the next question. And Alex will try it again and we'll see if it works better the second time. Okay, so diagnosis should be confirmed by skin biopsy, serum IgE levels, scraping of lesions and then doing a microscopic examination, or none of the above.
Okay, let's. Okay, are we able to see it?
I can see it. All right, I submitted.
Yeah, I think there's just trouble with being able to get the results in. It's very weird.
Okay. Would everyone do me a favor, since we're having some trouble sort of seeing everybody's answers, if you wouldn't mind, and again, you're not getting penalized if you don't have the right answer, that's okay. But would everybody just mind putting their answer in the chat box, sort of typing what they think the answer is in the chat box, and then that'll just kind of give us an idea of, again, I'm kind of using this as a knowledge check to see how we did, and if we need to sort of hit any other, come back to reinforce any topics before we end.
Oh, great.
Great, thank you. All right, it looks like almost everybody unanimously put, there's a couple different things. So, and this is a little bit, and I didn't mean to make it a tricky question. Technically, so you could do serum IgE levels to sort of confirm the diagnosis. But really, I think the most appropriate answer is none of the above, because I will tell you, in 21 years of practice and seeing many, many, many kids with atopic dermatitis, I'm pretty comfortable for the most part making that diagnosis. And I have not done serum IgE levels. I'm not saying that you couldn't do that, but I would say for most of the kids that we are seeing with mild to moderate atopic dermatitis, it really is a clinical decision, and I would probably not order serum IgE levels. Now, if you weren't sure or there was some other allergies going on, I think definitely a serum IgE level would be correct. So next slide. Or next question. Okay. How would you classify the severity of AD's atopic dermatitis? And we're going to go back to the Investigator Global Assessment, the IGA scale that Dr. Shah had talked about earlier. Would you say that it's 0, 1, 2, 3, or 4? Clear, almost clear, mild, moderate, or severe? And if everybody, you can either put the number or you can write the word. Again, just trying to get a sense of what everybody thinks. Give everybody another few seconds here to answer. So it looks like we have a little bit of a range. Some people said mild, some people said moderate. I actually felt this was moderate due to sort of the degree of erythema and some of the xerosis. And I believe when Dr. Shah presented this picture, I think she also noted that it was moderate. But again, my point was this is a mild to moderate classification of children with atopic dermatitis. And I think that's going to be important when we get to a future question. Next question, Alex. And so again, I said moderate. And again, this is just if you want to leave this up for just a second, Alex, again, this is just that assessment scale that Dr. Shah had put. And I think I called it moderate because if you look, mild, slight, but definite erythema, I thought it was a little bit more red than pink. And that there was clearly some induration. But I really did not think there was any oozing or crusting. So somewhere between, and I think Kara said you could actually do decimals with this, so it may be 2.5 is really sort of the correct answer. So next slide, Alex. So if we're going to agree that this child has somewhere between mild and moderate atopic dermatitis, yes or no, would you refer this patient to a pediatric dermatologist? If you just want to put your answers in the text. I like that. Jennifer went rogue and put a different answer, but I like it, Jennifer. We can handle it. Alex, you want to get to the answer? I would agree. This should be a patient that we can and should be handling in our practice. And it's definitely, I think, a referral that if we send it to Dr. Shah, she would be happy to see the child, but in the back of her mind, she may be wondering, I'm wondering why this pediatrician sent me this patient. I need to do some community education and outreach because this is something we should be managing in our offices. So next slide, Alex. Okay, this is a long question. So treatment options. Would you recommend, number one, using a synthetic surfactant-based detergent for skin cleansing like Cetaphil and liberal use of skin emollients? Would you recommend bathing at least 30 minutes, no more than 3 times per week? Would you recommend use of a wet wrap after bathing? Would you recommend use of fluocinolone 0.05% twice daily? Would you provide the family with an eczema action plan? Would you do all of the above? Or would you do varying combinations? You could do 1, 2, and 3. You could do 1, 4, and 5. Or you could do 1, 3, and 5. All right, Alex, you want to go ahead and advance? Getting some good answers. So I said, and again, I really like, Jennifer's comment about the caveat of sort of asking the family about the willingness to do wet wraps. I sort of felt the most appropriate if the family's willing, and you sort of have gone over some adherence, sort of doing, number one, using Cetaphil, use of a wet wrap after bathing, and providing the family with an eczema action plan. Fluocinolone may not be a wrong answer if this were a child that was having a flare and was already using a lower potency topical corticosteroid. But assuming this is sort of initial visit, I would probably start with a lower potency topical corticosteroid. So that's why I chose those as the answer. In regard to diet, the family should be counseled to, number one, switching to a hydrolyzed formula. Number two, strict avoidance of peanuts, both of those, or none of the above. You guys are getting the hang of it. Great. Alex, you want to advance and we'll look at the answer? And I think almost everybody said none of the above, correct. I do not think this child would be a candidate for hydrolyzed formula unless they develop blood in their stools and you were maybe concerned about cow's milk protein allergy. And Dr. Shaw sort of mentioned the LEAP study in regards to atopic dermatitis. So next slide, please. All of the following examples of successful principles of adherence include everything except keeping the treatment plan simple, helping families to prioritize, or telling the families what you think the best treatment plan is. So which of those is incorrect, would you not do? All right, Alex, let's reveal. Exactly, right? Telling the families the best treatment plan. You really want to do shared decision-making, as Dr. Harris went over so well, and really asking the families, what are your priorities? What are you hoping to tackle at today's visit? Next slide, please. And then let's talk briefly about comorbidities. See if you remember, which of these disorders is AD at greater risk for developing because of his atopic dermatitis? Is it ADHD? Is it mood disorders like anxiety and depression, sleep issues, impaired quality of life, impaired school performance, low self-esteem, or all of the above? Alex, you can go ahead and reveal. I think most everybody's got the correct answer. So again, another great reason to keep these kids in our primary care medical home, because these are all things that we will be dealing with as primary care pediatricians that we need to, number one, be screening for and on the lookout for, because we know they're at greater risk, but then also we are in great position to help counsel these patients and families in dealing with these other disorders, be it ADHD and school problems or sleep issues, those sorts of things. Next slide. Okay, thank you all for playing along and kind of being flexible with our technical challenges. The last couple of minutes before we get to a final question and answer session is I want to introduce the quality improvement MOC project that the Ohio chapter is rolling out. I know some of you have agreed to participate, and that's fantastic. So this will give you a little bit more information. For those of you that haven't or weren't aware of it, it's a little bit of information. If you are interested, Alex will follow up with you and talk to you about how to get signed up. So we're calling this quality improvement project Atopic Dermatitis, Building a System of Care Learning Collaborative. Next slide, Alex. The goal is to improve the outcomes of our patients by increasing the knowledge, confidence, and competencies of primary care providers in recognizing, diagnosing, treating, and overall managing the care and adherence of pediatric patients with atopic dermatitis. This includes making and completing appropriate referrals and managing symptoms and medication for patients with mild symptoms, and I would even argue moderate symptoms, or while patients with moderate to severe symptoms are awaiting specialist appointments. Next slide, Alex. This is our key driver diagram that the team came up with, and we're going to sort of break it down over the next several slides. But you can see we're going to, our key drivers all relate to our aim, and we're going to do some measurement of data. We're going to provide resources and education to both providers, and then also give you materials to help educate our families and patients, and then also look at environmental factors such as office flow, increasing diagnosis and quality of life screening, and access to handouts. So let's break that down a little bit. Next slide, Alex. So again, the global aim is to improve the knowledge and ability of providers to manage atopic dermatitis in the primary care setting, addressing all of those various issues. The project is going to kick off on July 1st, and it's going to end in June 2021. And there is a link for, if you want more information, to register. These are some of the things that we're going to be providing: practice coaching with monthly check-ins, free resources for you to use for your families, creating a sustainable process around atopic dermatitis diagnosis and treatment, and then helping you with office flow and quality improvement training, and really doing a PDSA, several PDSA cycles within your practice to help you accomplish all of those: plan, study, do, and act. Next slide, Alex. So our global aim, again, improving knowledge and ability of providers to manage atopic dermatitis in your primary care setting. The specific aim is over the next year, beginning in July, each practice will work to improve proper recognition and diagnosis of AD in their patients, improve delivery of anticipatory guidance, and assist families in adhering to suggested treatment strategies, overall to improve care for our patients while decreasing referrals to dermatologists for mild cases. Next slide. We've identified several measures that we're going to really help to impact positively. The first is participant confidence increase. Really looking to provide confidence for providers in discussing aspects of atopic dermatitis in the primary care setting. Our goal is 85% of providers enrolled will report an increase in confidence in discussion of atopic dermatitis. So we're going to do a pre-test survey and then a post-project survey that will be done during the pre-work surveys and then during exit interviews at the end of the project. And so our goal is 85% of providers will report an increase in that confidence. Next slide. We're going to look at increasing the use of diagnostic screening. So the primary care providers will attempt to perform a diagnostic screen for all patients with a chief complaint of atopic dermatitis or a previous diagnosis of atopic dermatitis to determine diagnosis and/or severity. Our goal for implementation of screening for patients is 80% of pediatric visits in children who present with signs and symptoms of atopic dermatitis. And we're going to be having you do some chart reviews of patients with chief complaint of atopic dermatitis or a previous diagnosis per month. And that's how we're going to sort of see if we hit that 80% measure. Next slide. Our third measure is use of atopic dermatitis materials. So the primary care providers will use atopic dermatitis materials for all patients with the diagnosis. We're going to utilize discussion and management materials with 90% of our patients that we see with a chief complaint of atopic dermatitis. And again, this is going to be accomplished by doing chart reviews. And these are RAC cards and other materials that the chapter is going to provide for you to use for your own education as well as the education of your families. Next slide. Want to look at plan of care for our patients with atopic dermatitis and having the primary care providers recommending in a plan of care. Our goal is going to be 90% of patients with a chief complaint of atopic dermatitis or a previous diagnosis the PCP will have recommended a plan of care. And again, this is going to be calculated by chart reviews. Next slide. And then quality of life screening. The primary care providers will attempt to perform an evidence-based screening for all patients with an atopic dermatitis to determine their quality of life. And our target is that a parent or child questionnaire will be completed on quality of life patients with the chief complaint of atopic dermatitis or a previous diagnosis. And again, we're going to be using chart reviews. Next slide. And then decreasing in referrals, as we mentioned. Our goal is that during a 3-month period comparing to baseline over a 3-month period, referrals to a pediatric dermatologist for patients with mild atopic dermatitis will have decreased by 75%. I should say mild to moderate cases by 75%. And again, calculation will be done by using chart review of baseline data at the beginning as well as throughout the project. Next slide. So what are the expectations of our provider participants? We're going to ask that you organize a core team of at least 3 members. That it would include a physician leader, a nurse, nurse practitioner, or a medical assistant, and somebody in the front office or administration, be it your staff or somebody in your front office, who would really commit to being the day-to-day team contact. All 3 members will attend a kickoff meeting that one of the chapter staff will lead and meets at least bi-weekly to plan and carry out tests of change using the change package. Secure leadership from senior leadership, whether that's in your practice or in your institution, for the improvement team's work in the collaborative, and then aligning the goals of the collaborative work to the strategic plan of your organization. Next slide. We're going to ask that you perform some pre-work activities, which is going to include a practice assessment and collection of some baseline data. You're going to do some chart reviews. We might ask you to do some inventory of your systems, coming up with a practice-specific aim statement. And if you've never done that, our practice coaches will walk you through step-by-step how to do that, as well as some surveys for your providers to get a baseline knowledge assessment and confidence level. We ask that you attend a practice kickoff meeting with the practice coach, which most likely will be virtually, given where we're at in the world right now, but some may be on site, depending on what you're able to accommodate. Complete education through the chapter on atopic dermatitis through a live webinar, which you are doing right now. And then performing tests of change that lead to improvement towards the desired outcomes, and submission of at least 3 Plan, Do, Study, Act worksheets and 1 sustainability PDSA worksheet. And if you're looking at this and it looks great to you, don't worry. Again, the practice coaches will walk you through how to do this. This is not as hard as it sounds. It's actually very easy. Next slide. We're going to ask you to collect data at the point of care through chart reviews of patients who present with atopic dermatitis for a 9-month period. We're going to ask you, and we're going to help you and teach you how to submit a completed office flow or process mapping diagram. We're going to ask that you participate in monthly phone calls, which will be about 50 minutes in length. We call them action period calls, which are teleconferences and webinars, as well as having a listserv where really we get to learn from one another and share improvement ideas and tools and what's worked for your practice, or what is your practice struggling with, and maybe another practice could help you with that. We are going to be able to award American Board of Pediatrics MOC Part 4 credit, and it's actually a fair amount of credit. Since this is a fairly longer quality improvement study, the project has been approved for 50 Part 4 MOC credits. And then you're going to be submitting monthly data for some of those measures that we went through just a few minutes ago through chart reviews. Next slide. We're going to ask that you submit quarterly progress reports to the collaborative leadership for each practice through your practice coaching meetings, sharing and reviewing practice identified data transparently across the collaborative. Identified practice data cannot be shared outside of the collaborative without permission, so we will protect your data. And then for the physician practice leader only, serving as the local leader in your practice or organization and attesting to the providers in your office or clinic that basically you're signing off saying, yes, they had meaningful participation in this project and they should be awarded the Part 4 MOC points. Next slide. What will the project team do for you? We're going to provide evidence-based information on atopic dermatitis for your patients, including symptoms, adherence to treatment, mental and behavioral health aspects, and implementations of best practice into primary care. We're going to provide practice coaching on applying the model for improvement. And if you've never done a PDSA cycle, we're going to teach you how to do that. And there'll be ongoing education and communication throughout the project. We're going to be giving each team monthly feedback on their data and their project reports, and providing web-based workspace for posting of individual teams' data and reports, and a litany of tools and training materials. Next slide. We're going to provide printed materials that you can use with your families to discuss treatment plans. We're going to provide documentation of the project results for you and your partners and providers to meet ABP certification standards, providing communication support to keep teams connected to us and to each other throughout the collaborative, and then offer any technical assistance for quality improvement data space. Next slide. So this is just a timeline of what we're tentatively looking at. The kickoff period will run through the end of the month, and for practices that it may actually go past that, but we're really looking to officially kick off on July 1, where our first quarter, we're really going to focus on implementation of the project and helping you figure out your office flow. The second quarter, we're going to really focus on social, emotional, and behavioral health focus. The third quarter, we're going to focus on referrals and partnerships. And then during that fourth quarter, when we start to wind down, we want to focus on what have you learned from this? What has worked for you? What's important for you to keep doing in your practice once this collaborative project is over? Next slide. Again, we're going to be enrolling through the end of this month, and honestly, even a little bit later into that or until our spaces are filled. There's going to be some practice kickoff coaching meetings via webinar that'll be taking place, I think, beginning next week for some practices. Today, obviously, we did the webinar training, and then for those that were not able to attend, that's going to be archived and they'll be able to watch that. We'll have some baseline data due. That June 30th date is not hard and fast. It's obviously going to depend on when you have your kickoff meeting with your coach, and then we look to launch on July 1st. Next slide. Action period calls will begin in July and go through May. You'll be having some practice coach meetings. We ask that you submit your chart review, and again, we'll tell you exactly what we're looking for in those chart reviews and how to submit those monthly by the 5th of each month. And then there's going to be some dates on when we would like you to submit some PDSA cycles, focusing on different things, generally under those umbrellas, whether it's office flow, behavioral mental health, referrals, or sustainability. And those will be reviewed during your quarterly coaching meetings. Next slide. This is the link where the data collection will be completed. We're, again, looking for patients with eczema as a chief complaint or a previous diagnosis. Ideally, we're looking for 10 charts per month, or all patients with eczema as a chief complaint or a previous diagnosis seen in that month, whichever is smaller. So for instance, if we have 2 physicians, we'd be looking for 20 charts per month, ideally. We're going to be collecting baseline data initially, and then monthly data really beginning in July. Next slide. I mentioned the 4 PDSA cycles that'll sort of be focused towards those 4 different areas that I had mentioned. We're going to have you complete the PDSA cycle, and you can either scan an email or fax it in. And we just ask that there's 1 PDSA worksheet per practice. So not every provider has to do their own PDSA cycle. It'll be 1 PDSA worksheet per practice each of those quarters. Next slide, Alex. This is a rough outline of some of the topics that we plan to cover during those action period calls. These may change depending on the needs of the group and as we're rolling out the project. But these are some of the things. I won't read them all, but you can see some of the topics that we plan to cover during those monthly action calls. And we're planning right now on those to be at about 12:15 to 1 o'clock. Next slide, Alex. I'm going to turn it back over to Alex, who, again, we open it up for the chat box for any questions. If you have diagnosis treatment questions for Dr. Shaw, if you have adherence questions for Dr. Harris, if you have a question about the quality improvement project for Alex or I, please put those in. Alex, I'm going to turn it back over to you.
Yeah, great. Thank you to Dr. Shaw, Dr. Harris, and Dr. Peltier for presenting on this topic. And we appreciate you actively participating in the case as well. I'm sorry that the polling didn't work out the way that we wanted it to, but I'm glad that we were still able to work through that case. So I took note of a few questions that were asked at the beginning after Dr. Shaw's presentation. So the first one is if Vaseline and petroleum plus water is a reasonable alternative to Dermaphor or Aquaphor?
Vaseline, as long as it's actually a Vaseline ointment and not Vaseline lotion, You can certainly use in substitution with things like Dermaphor, Aquaphor, yes, etc. You don't need to add water to it though.
Okay. And then how young can you give a bleach or antibiotic bath?
So you can really do, bleach baths or any type of antibacterial cleanser at any age. I tell people that giving a bleach bath or making a bleach bath is basically the same as, putting your kid in a chlorinated pool, with some exceptions, but the principle is the same. So it's certainly safe to do. All of the standard antibacterial cleansers that were mentioned are things that you can use, in any age with all the standard precautions. Try not to get them in the mucous membranes, and make sure you're washing them off and not overdoing it, etc. So yes.
Great. And then our next question, and I can try to answer this, and Dr. Peltier, you might be able to help as well. We have a new provider starting in July. Would he be able to do this project since he won't have any baseline data?
Yeah, I don't think that'll be a problem because it'll be easy to measure. I think directly the biggest thing we'd want to get is the pre-questionnaire and sort of confidence and around managing atopic dermatitis. And Alex could be able to get that to you. You could get that to the new provider before they start, or even once they start. I mean, we can be flexible. It doesn't have to be that. We can get that data. I don't think that'll be a big issue at all.
We'd love to have him still participate. So that would be great. Are there any other questions for Dr. Shaw, Dr. Harris, or Dr. Peltier before we wrap up and I show some of the resources that we're going to be providing for the project?
I'm just going to make a comment. For those of you that have signed up, thank you. I think it's going to be a great project. I know Kara, Emily, and I, we've been working on this for almost a year now, and we're very excited that we're launching it. And I just want to say, just the resources that are available pretty much for the next year. Now, they're not going to see your patients in their office, but really for the next year, at least once a month, you're going to have access to learning and bouncing ideas off of a pediatric dermatologist and a pediatric psychiatrist. And we all know in primary care, that is hard to do. It's hard to because of their schedules, get regular access to a dermatologist or a psychiatrist. So that alone, I think, is worth the effort, besides obviously all of the benefits that this is going to bring to your practice and your patients. So
these are some of the RAC cards that we'll be providing for families, and we're still in the process of creating some additional resources. So we're really excited to share those once the project kicks off. But this is just a sneak peek of what we'll be offering, and we're excited to share these with everyone that will be participating in the project. And like Dr. Peltier said before, if you're interested in participating and you have not yet signed up, please send me an email, and you can also go to the website and sign up there as well. If you have any questions, please let us know. I'm more than happy to answer those for you, or even set up a call to discuss it more in detail. And I think that is all that we have for the training. Like I said at the beginning, I will send out a survey tomorrow morning, and that is how you will receive your MOC credit and any certificate for participation that you may need. And if you joined us a little late, we will post this webinar, make sure that you have access to the recording, as well as the PowerPoint presentation slides.
And I'll just say, Alex, for I'm assuming probably there's only one of you from each of your practice here like I am. I plan on sharing this webinar and the slides with my partners. It's a great way to get them some education and get them a little bit more comfortable as well. So,
yeah, that's a great point.
I'm excited to learn as much from the practices as you bring questions. So bring it and help us help you. Thank you.
Yeah. Thank you, everyone, for attending.
Thanks, everybody. Have a great day.
Yeah, have a great rest of your day, and please feel free to send an email. If any additional questions come up, please let me know, and I can make sure that Dr. Shaw, Dr. Harris, and Dr. Peltier receive those questions and reach out to you to answer them. Have a great day.